long walking around. I will walk around, but we'll be moving on because the technique is very similar. Okay, it's just a variation. Adrian, can I use you? Yeah. So we're gonna do the lower thoracic. I'm gonna sit face that way. So we're gonna move on to the lower thoracic one now. So this time is gonna be, think about where the bra strap would be for a woman, about T7, 8. So we're gonna go below the inferior angle. So don't go too low, like T11, 12, because it's unrealistic. So go around T8 or T9, maybe 10. So we're going to manipulate that sort of area. Now, what do you think will be different? How would you change the technique? So the first one will be what I call a thoracic thrust. So it's almost like hand sternum parallel. How would it change for 9 or 10, T9? Position of the patient mainly. More flexed. Yeah, so there'll be more inflection. And your hands will come below your sternum. So it's almost a thoracic lift. Okay, you're going to be lifting up rather than thrusting back. Yep. Okay, so it looks similar, but there's a slight variation. So let's go through that technique. Come back towards me. Remember them to you. Keep going on. Sit back. Yeah, a bit more. Keep going. Keep going. There. Okay, so get them back. Otherwise, you'll be reaching to them. The tightness of a towel is important. Okay, as tight as you can get this. So find T7 and go to T8 or T9. So I'm going to go a bit lower. Around here. Okay, rather than say there. Now, drop down to that level. Same with the arms. So right under, hold, hold. Flex them down further. Okay, so you flex them further down. Fine tune your position. Come under. So now you're going to be lifting up like a 30-degree angle. So you're going to come up. See that? So it's up to you. Take a small breath. Breathe out. Lock. Thrust.
That sounds good. Is that good?
For who? Me or him?
You never say good.
No. Stop it. Don't be cheeky. Yes. Okay. I know, make it look easy. It's frustrating, isn't it, sometimes? But just think of many times, as I said, it's like anything, you know, you almost need, like I'm trying to learn a piano at the moment, it's just ridiculous. You know, but I'm like, I go to the lesson and I have an hour with her, and I might do 10 minutes in between. Yeah, so when I go back, have you done it? No, just, I'm trying to do a bit more, you know what I mean? But, you know, I'll never be able to turn up at an airport and there's a piano and just off I go and do my thing. Yeah, I was like, can't even play chopsticks. No, I know I need to read the music, but she said it's like anything, John. You just have to practice and practice and practice and practice and practice. Yeah, I'm also trying to learn wheelies on a motorbike. Yeah, like on a dirt bike. But you know, someone said you have to practice and practice and practice. If you're only practicing like 30 seconds every now and again, you're not going to be any good at it. And it's like this: if you're only doing it a little bit, don't expect to become amazing at it. Okay, if you do it every day on almost every patient, okay, it will become easier, okay? But we're all on a ladder. We're all climbing up. As long as we're climbing up, okay, to progress and don't stagnate, then you'll do okay. Obviously, you were here to learn, yeah? So try that one and see how you get on.
I think there's a benefit to doing that as opposed to doing mobilizations or MATs.
Well, it will be a lot quicker, for one, to get the same effect. Mobilization actually takes longer. Okay. Sometimes what you have to remember is it's like my friend tries to explain it, that if you've fallen off something and you landed with force, you almost need equal force in the opposite direction. Okay. So if you fall on your pelvis and it's going up, you need force to pull it down. An MET and mobilizing will never change it. So you almost need a force in the opposite direction. Like if you've been playing rugby and someone's hit you like that, and the neck has gone over, and you can massage it all day.
It might move eventually, but it will take some time.
You might take some time. Yeah. Everything has its place, but for chiropractors, it's only manipulative techniques. They'll never mob. Yeah.
Just got some stiffies in my.
Yeah, well, if it's too stiff, it's going to be you'll be forcing stuff.
Sometimes you just need a.
Yeah. Sometimes for them, it's probably more benefit to mobilize than it is to manipulate, because you might be forcing. Yeah.
I posted something else.
Yeah. But yeah, it's cool.
That one right is there.
Yeah, that's right. We can't. Just try that, Evelyn. Not bad. Yeah, the angle's perfect. The thrust was there. Too fast. Well done.
No, I was still.
I've only just got a message saying you're in the wrong building. Yeah, because I don't tend to
We
look
came
at
all the
that.
way up and we were like doors locked, then we went all the way back down.
Yeah. Right, you're probably going to struggle putting it there. When I'm doing it, I know it's probably men might find it a little easier than a woman. Okay, it'd still be on
I
my
was just
sternum.
adjusting it, I'll go down. Yeah.
Yeah. So if the couch is probably a bit low.
Yeah.
So if you want to go there, you almost have to drop down to it.
Yeah.
Okay.
It's our hydraulic bed.
And then you're going to come up and then that way. Okay. But yes, hydraulic couch would be a lot easier.
That's what we have.
Yeah. Maybe just if you're not sure, sit in that couch.
Oh, it'll be fine.
Yeah.
I'm very sprightly.
Yeah. No idea. I've eaten it. Well, there's enough towels around, so it should be 10, 11. There's one. Which one? Well, Adrian took it to go to the back. He took one. But it must be enough. It must be another towel somewhere. Yeah, there's one. There you go. Yeah.
See?
Yeah. You're a what? Crap walk?
I'm a crapper.
All right. Yeah. We're working a 3 or 4s, okay? Yeah. You could do it gently. Yeah. Gently-ish. Yeah. Because it'll be okay. You're not going to...
The thing is, it's like I'm quite flexible. So
Yeah.
yes, it's kind of,
That's right. True. Yeah, that's true. Everybody okay? You okay? Yeah.
Makes you end his lunch in a bit.
You're trying to squeeze up, but everything you're doing is fine. You just have to be a bit quicker. Yeah. Because remember, it's a thrust. Okay, rather than a squeeze. Okay, so take a breath in, both of you. And as you breathe out, you pull, you push, you lock, thrust. Huh? Yeah. Yeah. But you're still trying to squeeze it in. You still almost have to pull. Then it has to be definitive. Pull, tension. If you don't, it's a mob. If you do, it's a manip. Okay? Okay? It will come. But what you were doing was okay. Just sit on the end. Yeah. Yes.
What position should
The same as before. So right under is the way I do it. Doesn't mean it's right. It just works for me. Hand on the elbow, slump. Hand on the other elbow. So you're going to come under and lift them up this way.
So you don't force them down anymore.
No. Well, yeah, in further flexion, yes. Yeah, only flexion. And then you're almost coming under there. Yeah? He's not the easiest because he's a bit stiff and he's a bit wide. Yeah? Okay, so if you look up and say rugby team, they're going to be bigger, aren't they? Yeah. All right?
No.
What's the matter? Well, this one's not the easiest to get.
I think I'm pretty locked up there as well.
Okay.
Around my
I don't know if I'm
TL.
doing it right.
I'll try. Have a go.
Right over left.
Well, right under left
Right under
is
left.
my preferred way. Not that it matters. Hand, flex it down. Hand on your elbow. Okay, so you're gonna. It's almost trying to lock. Okay, breathe in. Breathe out. Pull. Push with your chest. Lock.
Oh yeah.
Well done.
So that was right.
Well done.
Yes.
Well done.
Yes.
High five.
Yeah.
Thank you.
Laura, you were trying to extend her. You have to keep it in flexion and manipulate in flexion. Yeah, because you're almost trying to close.
Right.
So maintain her inflection.
Can you take a big breath for me?
Right, you were trying to pull it up, okay? Almost like an angle. So it's a thoracic lift up.
Take a big breath again for me.
Good. Not bad, but you pulled more with the hands and you pushed with your chest. Okay?
So it's more. Sorry.
It's almost a.
I'm making sure I don't finger
No,
the
yeah.
extension.
Yeah.
Okay.
Yeah. There's a lot of things to think about. Yeah. Like a mob is quite easy in some ways. Yeah. Because there's no risk.
Yeah.
Yeah.
See when we're breathing out. Do it at the end of the breathe out.
Yeah. Well, as long as you're breathing out.
When I did it to you, it was better. One side the next side.
Yeah. You have to be as if relaxed. You don't want to be breathing in and manipulating.
Yeah. It's like we're breathing out. And then it's like, it felt like for me as well.
All good?
Yeah,
How are you getting on?
we did
Yeah.
we did the thrust now, both of us.
Yeah.
Oh, good, yeah.
Good luck. Okay, next. Next one. Adrian, you're trying to squeeze him. You're trying to squeeze. It will cavitate in some, but it will cavitate in some people when you squeeze. But if you want to manipulate, it has to be a separate thrust. Okay, so you pull. So everything you're doing is fine. It's just that the last bit, almost the most important. Yeah. Okay, so try to be more. Think of a chest draw. Rather than just pull in, squeeze in. But no, you're going to be more. So it's a pull up. Yeah, it has to be a definitive thrust to be a manip. Okay, rather than a squeeze. Next one. Do you want to come around, please? Costin, let's try you. Head forward. What part of Romania are you from? Transylvania?
No.
No.
Just in between Bucharest and Brașov.
Okay.
Buzău.
Okay. I call it the CD junction. Cervical, dorsal. Dorsal is the old name for the thoracic spine. If you want to call it the CT junction, it makes more sense. Cervical, thoracic junction. So it is C7 on T1. We can mobilize into T1, T2 as well. We just change the cervical position. So a little bit more flexion will bring you a little bit lower. Potentially you can get T2, T3. Depends on the angulation. I mentioned earlier, I think you said the nerve, didn't you? Between C7 and T1, it was yourself. So C8 nerve and C8 and T1 become a little bit 7. Yeah, the ulnar nerve. So the ulnar nerve, if you were going to test the ulnar nerve, what might you do? Okay, so okay, well that's more of an up. Okay, neurally, yes, you can do that test. Okay, it's like an upper limb tension test. So you were doing. That's the median nerve. So if you're doing that test, okay, this test, thumb and index, that's the median nerve test. Where does the median nerve come from? C5, 6, C7, C8, T1, okay? So C5 is all brachial plexus. And the median nerve will go through which tunnel? The carpal tunnel, okay? And then it will supply a thumb, index, middle, and half a ring finger, yeah, along here. There are 10 structures that go through the carpal tunnel. Okay, you got the finger flexors, flexor digitorum superficialis and profundus, and the flexor pollicis longus, median nerve. Okay, 10 structures within the carpal tunnel around here. So basically, it'll supply that sort of area. The thenar eminence, they call them the loaf muscles, the L, the O, the A, and the F around here. Okay, so if you've got a weakness of the loaf muscles in here, the thumb controllers, yeah, and then you might find it's a median nerve issue, not really within the neck, not really within this area, but maybe within the carpal tunnel. Now, the ulnar nerve will go through another tunnel in the hand called a what? It's between the pisiform and the hamate. What muscle attaches to the pisiform here? I can help you if you want. Flex the carpi ulnaris. Okay, and then attaches to the pisiform. And then from the pisiform to the hamate, there's a ligament called the piezohamate ligament, and it forms the roof of the tunnel, and the tunnel is called the tunnel of Guion. And the tunnel of Guion is the pathway for the ulnar nerve to go around and supply the little finger and half a ring finger. If you resist abduction, you are testing which muscle? Abductor digiti minimi. Okay, if you're doing this test, which is opposition, so you are using the muscle to bring it over to the thumb. Okay, so it'll be like the opponens pollicis for the thumb, and then it will be opponens digiti minimi for the little finger to bring it over. So you test the median nerve and ulnar nerve when you do that test. Okay, if you push your little finger away, it's only ulnar nerve. Yep, so it's an abduction of the little fingers of a test. So it could be irritated from in this sort of area in here. So we're going to start with the C7T1 to see if it would change this sort of area. Now, when we do this one, we don't really need the towel unless you want to. So what we're going to do with Cusson, we are going to watch the way I do this, okay? Interlock your fingers behind your neck is the way I watch people do this, both hands. And then what people do then is they put one hand under, and it's fiddly, it's awkward, okay? From there, and he's not the smallest guy, okay, to do this too. Watch the way I do it. So we start, hands come through onto their forearms. Interlock your fingers behind your neck. Okay, I'm already there. Okay, I'm already there. Now, to protect the shoulder, bring your elbows in a little bit. Okay, so not too much because you force. You protect the shoulder by bringing the arms in. Because what you don't really want to do is when you do the technique, you don't really want to use the elbows to come out because it might irritate the joint capsule of the shoulder. And if you've dislocated the shoulder, they won't like it. Okay? So try to keep the arms in to protect. From here, I'm going to try to get my upper chest onto his upper back, and I'm going to use my chest and try to mobilize using my sort of chest. That's why, ladies, you might want to use a towel if you find it's easier for you. Let's run through this. No. So my hands through, fingers behind your neck, please, interlock. So I'm already there, below. Okay, bring his elbows forward. He's not the smallest, okay, but I wanted to show you on a bigger person. So from there, I'm going to bring my upper chest onto his upper back. Relax, let go. Okay, I just have to play around with him for a minute. So from here, I'm going to bring him back a little bit. He's already went click. So I'm going to bring him back there. Okay, so I bring him forward and back, not too many times. And then it's a continuation of the movement from here, thrust. And it released as I'd expected to. All right? Yeah, so from there, forward, back. It's a continuation of the movement. A lot of people, when they're in that position, they change it. As they do that, they try to lift, because it might be known as a thoracic lift, okay? But it's a technique for the CD junction. So let me just show you again. From here, interlock. Bring elbows. So from here, I place my body up. I bring him back a little bit. So I'm just playing around with this motion here, see? No. Well, he's sort of he's in flexion of the neck, but he's still, even though he's extending, he's still in relative flexion. Yeah, so from here, can you see him teasing? Lock. So I use my chest just to push a little bit. So it's a continuation of the same movement. There's nothing stopping and going up or down. Okay, it's a continuation. Chest to draw in, bind, pull, cavitate. Let me just show you without doing it on you. Swap places so you can see. So someone smaller. Okay, well, she's be a bit lower, a bit more. For half of you, at least, as you go to do it, it will cavitate without thrust. As you go to squeeze and lift, it will go. Fingers behind your neck. Elbows forward. Forward. Okay, so I'm going to keep the elbows in to protect the shoulder. Upper chest over. Okay, and then from here, I'm just going to we just went. Okay, I'm not going to do it because I don't want to spoil it for someone. Okay, but it's a continuation move. That's what I mean. For most of you, it will go just by going through the motion. And then to add in just a little thrust, I cannot, for a lot of you, I could probably just, as I bring you up, I can almost just do this. As I lock you in with my arms, I guess, I can just do that, and it'll probably cavitate. Okay, without physically forcing. Lots of people force this one. Okay, we don't need to. Bring them up. Just a little technique, just a little end range thrust. You'll probably find if it needs to go and it wants to go, you give the body the right ingredient and it will go. Okay? Many of my friends, they force, it does go. The downside is that it's gone other places as well. Okay? And the joint capsules have just been irritated because you stretched everything else. And you wonder why the therapist then says, you're probably going to be a bit sore for a few days and take some anti-inflammatories. Yeah. And they go, okay, is that normal? Yeah. Not really. Okay. Yeah. Yeah, no, I referred one of my friends, I don't know why I did it, to this South African chiropractor. And he's very good, but he moves everything. Okay, he's a big lump, he's about 20 stone, and he'll just move anything. And I referred a friend of mine who's female. She said, John, I think I was crying a week later because I was in so much pain after seeing him. And I'm like, yeah. I don't know. I still don't know why I did it. Referred her because I thought he would have helped her change something, but I think he just set her on a path she couldn't get back from for a while. As in, like for a while, months. Yeah. After one session. Yeah. So I think she's still crying. I know. Yeah. Way too aggressive. Yeah. But then when you watch all the videos on YouTube, people are obsessed about the click, with the necks. It's almost like cameras next to the chiropractor. Yeah, and all that stuff. It's loads of force, loads of extension. Okay, they're just doing it for the views and the hits and they got millions of views and all that stuff. But people just do it intentionally. Yeah, that's that sort of thing. In fact, I met a guy yesterday in the red. He's the Nigerian big bouncer, and he said, and I was saying what I was doing. He said, "Can you teach me how to do it? Because I want to go to Nigeria and like do all of the filming and the views and try to get money on the YouTube." I'm like, probably not. Yeah, probably not. Yeah. He said, "Do I need to train in anything?" I said, "Yeah." Can I just tag on? Can I not just tag on to your course? I said, "No." I said, "No." Yeah. No. Yeah.
Nice try, though.
Nice try, yes. Nice try. Yeah. Good luck. All right. Yeah. Yeah, Auschwitz, we went to last time. Yeah, but no, I love it. I love Poland. Yeah, but I'm really been around Warsaw much, Krakow. Yeah, so because I drove Warsaw, Krakow, Wieliczka, Krakow, Białystok.
Cold part of the Poland.
It was snowing, lots of snow in December. Yeah. Yeah.
We all joking about it.
Yeah, it was good.
I stay here. I don't live in Poland anymore.
Oh no, I know. Yeah. Well done. You okay?
Yeah,
So you bring him in?
yeah.
You already done? You've done it?
Yeah.
Okay, well done. Okay?
I was just saying, do you think this is the one that's wrong on that one I was telling you?
No, probably not.
Her head's like stuck like that.
Yeah, it's probably a neck adjustment. It'd be quite rare to cause a problem with this one because it's only a C71. Yeah. Yeah. But if you're not happy, mobilize. Just mobilize. Yeah. Bring it in, bring it out. Just mobilize. No thrust. Yeah. Just bring it in, bring it out. And you might find a little cavitate as it is, like that. Yeah.
Am I doing it right?
Yeah. There. You okay, Amanda? Mm-hmm. Yeah. So that's a mobilization for this area. Okay.
Okay, and then but when you were doing the thruster,
Yeah. So it's almost like trying to from there. Try to use the upper chest just a little.
okay, right, right, breathe out. Did it?
Not bad. Okay. But it was almost like the chest draws in too far.
Mine went too.
The chest draws in and you hold and hope for the best. You have to feel a bind. Okay. So whenever you manipulate, you have to feel a resistance. Okay. So you have to find like a lock.
So I have to. So like that movement has to where I feel it and then.
Yeah. Yeah. So you bind it.
Yeah.
And then almost like at the end range tension, there's a tension point. The chest to draw, you can't just hope for the best when you pull her out. Okay. You pull. Where's the bind? There she is. Then you do it from the bind. The bind in some ways would be what we call coupled motion, but we haven't done coupled motion. Yeah, that's normally on the advanced course. This is just you increase tension, like with the arms and the neck and your chest, to the area. One is locked. You then thrust from the lock.
Okay.
Yeah.
Okay.
Otherwise, it's a mob, and that's safer if you're not sure.
Okay.
Yeah. Okay. Yeah. Okay. Yeah. 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 That's okay in that one. Yeah. Yeah. C71 will be fine now. Maybe not so far forward and so far backwards. Just play with that movement. Just a little bit of flexion.
Whether I don't think whether you're losing the pressure from.
Try to use the upper chest. What's your first name?
Sorry,
What was your first name?
Lisa.
Lisa, okay. Try to keep your elbows in a bit more.
Yeah.
Maybe use your upper chest. That's it there. That's it. That's better. So you use pressure in here. So when you're bringing it back, you don't have to bring it back so far now. Okay? And you can just use your chest just to push a little bit with your chest. Okay? Almost like you're just doing that. Yeah?
Right. Like that more.
Maybe don't go so far forward. So you just bring it back a little bit. Yeah. It's having the confidence sometimes, isn't it?
Yes, it is.
Yeah. To see it done is quite easy, but to try to do it yourself and have the confidence to do it.
Feeling anything.
But what you're doing, you are mobilizing, no?
Yeah.
Let me just see. Okay. So perceive the difference, Evelyn. Okay. Perceive the difference in feeling. Interlock. Elbows forward. So I try to do this as gentle as I can.
Further. Yeah. They're lower, I think.
Okay. So from there, don't do anything. Just let go. Let go. Let go. You just have to find where the bind is. Okay. Bind would be there. Okay. All right. So just a little. Yeah.
More.
For most people, that technique would be fine. Yeah.
With the smaller
The smaller
range.
movements, yeah, just a smaller lock in. That's where the skill level comes in. You find in the bind.
I
Yeah.
felt like it was more of you. Intention.
Yeah. Just lock in. Yeah. Good. Tiger looked okay. Look. Below her.
Getting a bit of elevation and lifting.
Yeah. Okay, Wendy? Yeah, looks okay. All right? Yeah, it probably will. Yeah. My friend who has a scoliosis comes to see me, he's from Sweden often, and I tend to do the CD and above. I don't tend to do too much in the middle. Yeah, if I'm honest.
I think it's always the same.
It'll always be.
And as I say, it moved once again. It's almost like distance wanting.
Yeah.
So if we get somebody in clinic with scoliosis,
Yeah.
movies, and then essentially you do the CT, and then maybe a little bit lower, did you say, or just do
Yeah.
the CT?
CT will be okay, but not too much force. Yeah, just to make sure they'll be okay. Yeah,
That actually went fairly easily.
it will do. Yeah, because it's almost like the end transition. Yeah, because most of the curve is like T-spine. Yeah, and obviously L-spine, but it's normally, yeah, and it probably doesn't normally need like just a little assistance. Yeah, and then that helps the neck in. Yeah. Yeah, like an owl. Yeah. Next one. Okay. Right, in the notes, there's another technique which is for the thoracic spine. There's always probably too much arm movement there. Keep your elbows in. Keep your elbows in. Yeah, 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 because your arms are like that out there. Yeah. For some it would work, but if you've got a niggly shoulder, you won't like it. Okay, so protect the shoulder and just gap the C7. Now, the next one, have a look at your own hand. Half of you will be okay, half of you won't. That's why I showed you the first technique using the towel. Not many people would use the towel because they use the hand. If you can't use your hand, you use a towel. So there's a choice. Now, can you do this? Look at the distal phalanx, the end phalanx, okay, as in, think about the proximal, middle, and distal phalanx in your proximal event, and intermediate or middle and distal, the phalanx. If you're looking at the end, can you flex the fingers, and can the distal phalanx become parallel with your metacarpal? No chance. Yeah. Okay. Yeah. Can you see that? And also, yeah, flatten. It's like anything. You have to train your hand. Can you have a spirit level on there, and it would be perfectly level? You're fine. Better on our end. Yeah, I'm not sure. You do it that knuckle. Okay. Try both hands because you can use both hands. You have to train your hands. It's uncomfortable. Okay. Yeah. So train. If you can't do it, roll your fingers forward. So you're using the middle phalanx, which is now parallel with the metacarpal. Most of you will be able to do that one. Okay, so this technique is known as the dog. Sounds a bit weird. It was taught to me as the dog, and I teach it as the dog. But I think, I think they teach it as AP thrust now, I think, in osteopathic school. So that would be a very common technique I would use. Now, if you struggle with this, try this. If you struggle with this, try like the cup-in hand, like this. Some osteopaths, chiropractors would do it like this. I can't. It struggles for me. Mine is always like this. Another way will be that, let's say you've got a bit of sponge or a bit of felt, okay, like under wrap for when you tape in ankles, and you just cut a bit off, and you roll it, and you place it in your fingertips, like here, okay, like a bit of sponge, and then you squeeze the sponge, and that then protects your knuckles from when you are rolling onto your hand. Yeah. So there's a few ways of doing it. Let me show you my way. The couch ideally would be a lot lower. I've actually done this. You can do this on the floor. I've done it on like gym benches. I've done it against the wall where I lean against my hand. Yeah, I've done it on the pool table in Turkey. So yeah, to the guy who runs the bar, and he got a bad back, and I said, oh, just lay on the pool table. So you know, you can adapt it to where you are. So I'll try. Let's lose you, if that's okay. Yeah, if you don't mind. If you place your head here. Yeah. Couch is a bit low, but we'll adapt 4. Most of these are too high. Face up. Now, when we're doing this one, most people struggle with the concept behind. If you think about it logically, the spine comes down. Like with this spine, all right, yeah. With this spine, can you see I've marked like a blue area? So let's say that joint is fixated. Okay, so that'll be T1, 2, 3, 4, 5, 6, 7. So T6, T7, it's closed on the left. This one doesn't really matter if it's closed left or right because it will open both sides. So it's not a positional manipulation. It is just a standard manip to gap either side. When we do this, so the patient is laying on the back like this. And then from there, we place the hand like I'm trying to show you. And then this MCP joint here is going to go on the vertebra. So if it's T6, 7, this knuckle is going to go on that T7, okay? Like this. So my patient, the reason I extend my finger, I always do that. Okay, so I'll show you in a second when I do it. So I place my hand on the spine like this. Okay, and then I rotate my hand, which increases the lever to that level. So the spine now sits down one of my lines in my hand along here. And then I roll them onto my hand. But then I manipulate through my chest, through her elbows, and I lean forward through. Let me show you an example of a setup. So when I do this, same with the arms, right and the left. If you go left and the right, it doesn't matter. It's just my preferred way. Like this, you okay? For a woman who's quite flexible, okay, look how far past her elbows go. I can't get my elbows to even come together, let alone go past. Okay, so from there. So you can hug something. She could hug a pillow between here. Yep. So it just makes the elbows level here. And it might be more comfortable, especially for maybe for a woman treating a man. The elbows and the chest could be a bit tender. So they could maybe put a pillow here. So the woman's chest is going onto a soft pillow to the elbow. Okay, so again, you can modify it accordingly. Now from here, so this is where we are. I will rotate my patient to me. Hand, spine. Okay, remember the bra strap, give or take, T7. Let me just show you, okay, so my finger will be like this, okay? I'm like this, so my finger is following the spine, there. Like this. So I will rotate my hand. So the spine sits in here. So the spine is there. So I would normally find the level and I rotate my hand. You have to try it as a tester first. Roll them onto your hand and see how it feels for you and for them. The bonus is this couch is very soft. Look at the amount of thickness of this sponge. In your hydraulic couches and your electric, they are a lot firmer. Okay, so they're not really forgiving. This one's almost too forgiving because the effort is absorbed into the couch rather than through their back. Yeah, so it's not that easy to get a cavitation on this type of couch because it's almost too soft and your hand sinks in. Yeah, but we'll adapt it accordingly. So that's where we would start. So if I run through an example without manipulating yet. So this is my setup. My arm, I roll. She's light, so it's easy for me, this one. Finger, rotate. Breathe, please. As she breathes out, I roll. I flex down to the level. I bring my chest up, over, and I would then thrust down through the elbows to my hand. The next time I'm going to lean on you a little bit. You okay for me? Yeah. But I'm not going to force. I'm just going to just lean and thrust through. And we see if it cavitates. If it doesn't cavitate, I'll try again. If not, that's me done. Okay? So you never see me really force in. My friend who was an osteopath, he said he's about 21 stone. He said, I'll manipulate you back, John. And he tried and he tried and he tried. And for about a week, I couldn't move my back. Yeah, because he said, I will get it to go. Whereas it almost puts you off. Okay? If it doesn't go 1 or 2, the body will protect. And it will bounce against you. So leave it alone. Okay? If in doubt, leave it. Just leave it. Yeah, we'll say we'll try next time. If we needed to. So this is where we are with the arms. So from here. Patient. Roll. Find the level. Let's say T6, T7. You can go T5 or T4 or T8 or T9. Okay, so you can play around here. Not so easy to get T1 or 2. That's better with a sit-in lift. So from here, breath in, please. And as she breathes out, flexor, down, click. Thank you. Okay? So just a little easy click. And it went exactly where my hand is. And that's the idea. Okay, I didn't go above it, didn't go below it. It went just there. Okay? No force. Straight down to my hand. Okay, the downside is you can't see my hand doing much work there, but I'm trying to show you where it is. And it's not changing. I'm not doing anything to it. It's just a placement. Okay, I've even done this where the guy is so big. Yeah, my friend's hand is there because he's an osteopath, and I thrust through his arms to his hand. Yeah, because I can't reach around him. Yeah. When I was teaching a course last week in Dubai, and this girl couldn't get the neck. Not I was showing neck, but I said sometimes I teach her, what do I call it? A four-handed neck manipulation. And she's like, what's a four-handed? I said, well, I do a neck, and then people can't understand the speed of the manipulation. So then I place their hands on the neck in the position that they would manipulate, and I place my hands over your hands, and then I set them up through your hands, and I feel where the bind is through your hands, and I manipulate through your hands, so you can see my speed. Yeah, but I got to feel the restriction through another set of hands. Do you know what I mean? Yeah, and then I do the technique through free hands, so you can feel my speed. Yeah, so it's I'm not sure if it's a it's a realistic technique in an osteopathic school, yeah. But I think for you learning and you're not sure of the speed, for me to do it over your hands, you're like, wow, yeah, that was quite interesting. And then you'll feel the clicks then under your own hands, but I'm doing it for you, yeah. Okay, yeah, and I quite like that. I got a YouTube video on that, the four-handed neck manipulation,
You could just leave her.
and do it.
Do it from the other side. Just with your hands.
Yeah. So if you are right-handed, you would use your right hand. But some of you all instinctively will naturally try your left hand. Yeah, so from here. So if you're using the left hand, it's no different, okay? So then you can bring the elbow to you this way. And then find the level from there, okay? Like this. Like this. Take a breath. And as she breathes out, you roll her onto your left hand. You flex her down. You come over, and then you would go through that way. I struggle with my left because I'm so used to doing it this hand. Yeah. Okay. But potentially I could. Couches for some are a bit high, but some are a bit taller, so maybe not so bad. Good luck on that one, our couch. Yeah. And good luck. Yeah. I might show you a four-handed neck after if you want. Maybe. Thank you.
Thank you.
Yeah. Try it. Yeah. This one, you can lower this one quite easy. I don't know how you do it. Is it you lift her up? How do you lift? Go
Must
down.
be able to lift that, surely.
Yeah. SJ, I'll do lower this one. How's this lower? Is it lower?
See if you. I just work in.
Probably pump that up.
Oh, it went down then, didn't it? There you go.
Then pump it up.
Yeah. Which one do you want to go to?
The whole spare at the bottom.
How many you want?
So three spare holes at the bottom. That's it.
Okay. Yeah. You might want to lower the couches anyway for the lumbar and for the rib springing. If it's a bit high, lower it anyway. Yeah. That's better. Yeah. Try it on your hands. Yeah, maybe same for you. Maybe I know you're taller, but you'll be okay. I think you're okay actually.
Like that, right?
Well, when I'm doing it, I'll be like this. That's it, like that. Okay. So then it'd be there, and then your hand would then rotate like that.
So now my knuckles on the.
So then you rotate over to your hand, flex it down to the level. That's what you have to do as a trial. Yeah.
Oh dear.
That's why.
I can feel
Was it your ring or? Oh, dear me. Oh.
Should be right.
Will it come off? Or yeah, put it away somewhere. Yeah. Yeah.
Okay.
Yeah, that's when you have to. It normally irritates the hand, or if you've got a ring on, you can dig in. So you have to, if you're doing it regular, like I would. So you roll her down, and then you have to stand up now. Stand up.
Stand up.
Yeah, and then you almost like use your body weight. So usually,
No, sorry. I
Yeah.
can just feel it going.
so you using your body weight
Uh-huh.
through her body into your hand. Yeah.
Oh,
Yeah. Yeah.
there was a wee click. There was a wee
Okay.
There was a
Yeah.
wee pop. Yeah.
Yeah. Well, sometimes either the finger clicks or the back goes.
No, it was definitely a pop.
Left-handed or right?
I'm right-handed, but when I went to do it, it's maybe my technique.
Yeah.
Right.
Middle finger. Normally, middle finger sometimes gets in the way.
Yeah, I
Yeah.
really felt I was going to snap it. I felt there was a lot of pain. Ow, that's what.
Yeah, as I say, yeah. So for you, either roll or use your other hand. Like, yeah, you could try that.
Yeah.
It's not the same, but it's okay.
Yeah.
Yeah. So then you shouldn't have too much pressure then. Yeah. Yeah. Yeah.
I mean, it's next to no pad.
Oh, this is okay.
Yeah, just hand position, right? So,
Yeah.
like that.
Flat. That's going to be sore.
Yeah, it was sort of. I
Yeah,
did
yeah.
try it,
Or you roll that way.
Okay.
Okay, and it won't be so sore. Okay. Or you just have your hands like that. Like that. There. Okay. And then potentially you'd have a sponge, something under here, but you squeeze. So when you squeeze the sponge, not rather than squeezing your fingers. Okay, because you can see how it can easily hurt your hands.
Like that position there.
Just do a trial roll onto your hand. How does it feel for him? How does it feel for you?
Yeah.
That's what I mean.
It's not uncomfortable.
Yeah, so it cannot be uncomfortable because they tighten up.
Yeah.
Yeah. Okay.
So that position there is going to be sort of.
Yeah, but the spine there.
Yeah.
So then he's going to sit in there. Yeah, some people will do it that way, a flat hand. Some people do it that way. Okay. Yeah. But a flat hand it's not so easy. Yeah. That's what I mean. Not every half of people here will not be able to do it.
Yeah.
Yeah, because of the hand positioning. Okay. Wendy, left hand or the right? Okay, that's good. It's fine, perfect. Just watch your rings, okay? When you dig in.
It feels like you're going to crack your finger.
Well, it will.
All right,
Yeah,
okay.
yeah. Yeah, it depends on how you do it. If you're doing it like that, it will feel like you're going to crack your fingers. That's why I try to keep them like that. Yeah, like that. So I train my hands to do that. That's okay. You'll be all right, yeah. You'll be fine.
Right.
Yeah, but train them like that. I mean, almost like bring them right over there. Almost uncomfortable in the top when you're doing it.
I've seen that thing on the rock tape. They've got like a manipulation tool. It's like a wee red rubber.
I have seen some in.
Yeah.
Yeah.
That's maybe
Something like that.
Uh-huh.
Yeah, yeah. Yeah, because it's soft and
Soft
it'll
and it
absorb.
goes kind of-
Yeah, but you're not going to damage your fingers then. Yeah. Yeah. Okay, one sec. Well, I'm helping you both here, so. Yeah. So your hand will be like this, so be flat, okay? Yeah, that's it, flat. So spirit level, flat. Yeah. So there, rotate. Don't worry about too much tension, just rotate it. Okay. And then you'd roll, just try it, roll onto your hand, see how it feels for you and for her. That feels okay? Yeah. And you flex it down to the level. But you have crossed the arms like this, but it would be okay, whereas mine would be that way. Okay, that's my preferred way. Not really matters that much. Okay. Breathe in. And then the pressure would be going down to your hand, free hand. That's it. Yeah. Okay, you try. That's what I mean, yeah.
Okay, I'm not completely level though.
We're trying. Well, rather than doing the finger, just do that.
Just do it.
Yeah, try to, that's it. You have to train your hand, it's uncomfortable.
Yeah. It's okay.
Yeah. All right, so then the spine sits in here.
Mm-hmm.
All right, like that. Yeah, there. Okay, just watch that knuckle.
It's the one I mangled previously.
Yeah. That's what I mean, lots of people have issue with a knuckle, and if you can't flex the finger, it will be so sore.
That one's been desiccated.
Yeah, from what? Sport?
Yes.
Yeah. Yeah, basketball and yeah, anything that it hits.
Right here. So don't do the finger.
Try it.
Right, try it.
Yeah, it works very well for me. Okay, but it doesn't work for everybody.
So about there.
Yeah. So the spine is there. Okay. So the spine.
Mm-hmm.
And you rotate.
Oh, sorry.
Yeah. So it's like opposite. It's not parallel. It's opposite now. Okay. So from there, just have a trial. Take a breath. Roller, flexor, down, 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 down. How's it in your back?
You okay?
Okay. And then you're going to be standing up more. So your body weight is going to go. Yeah. Yeah, just watch it, because if you push, it's going to be irritated, but the pressure would come down through. But you want to use, rather than use your hand to thrust, it's your body weight through to thrust. Okay.
Shall we try it?
Yeah.
Are you okay? I have consent. Right, so breathe in and out. Inhale.
But it didn't irritate it, no? Because if it's sore when I'm doing it, it's going to be worse than I thrust.
Keep the pressure on it.
Yeah, yeah. So you just have to, if you're almost there, just train and then practice and practice and practice. And if you're still not getting it, you have to go back to the towel one. And that would be the alternative. Yeah?
So the spine should be here.
Yes. Yeah. So spine sits in here.
Do you want to try it, buddy?
Yeah. You try it.
Lower back's killing me.
Yeah.
The position here, when you put your hand on, where's your hand actually sitting? Not actually on the spinous processes.
No, the spinous process will sit here.
Ah, right,
Yeah.
right.
So it's not parallel.
Oh,
You,
yeah.
you start. This is spine.
Yeah.
Okay. You're parallel,
And then you
and then you rotate.
straight that way.
So the
it's
spine now
straight-
sits in
it's
here. Yeah. Okay. So it's in here. So the spine is in there. So the spine is
there.
there.
Okay, with it.
So let's say that's your head and that's your leg. There. So you're parallel with the spine. The spine's here. Okay. And then you do this, and the spine sits in here now. Okay. And then that MCP stabilizes, say T7 or T8 or T9. Yeah. Yeah.
Watch your hands if you were doing it for Wendy.
About.
If you were
So try it on your hand. Okay, that's okay. Yeah, so the spine. So you bring her over. So roll her to you. So use your arm to roll. So from there, so you start there. You rotate. Okay, so the spine sits there.
Yeah.
Okay.
So you're working. So you'd already found out which side you're working on, right? So it could
Yeah.
be this side or
Yeah, it
that
doesn't
side,
matter.
right? So it doesn't matter. So
Doesn't
for
matter.
purposes, it's
Yeah.
this side, right?
Yeah.
Roll
And
it back.
take a breath in. And then you roll her onto your hand. See how it feels for both of you. You flex her down to the level. And then the pressure is going to go down through your hand on the out breath. So breath in, Wendy. And as she breathes out, through on the out breath, yeah? Okay?
So that was it. That's
As
it.
long as it's not uncomfortable for you and for her, it will be do okay.
And straight down.
Straight down through. Yeah, when you get some tenderness like that, obviously she feels it in her back. Yeah?
Yeah.
They will feel something, but they shouldn't feel any pain. Yeah.
So the way how we take the measure, so I took
Yeah.
the measure same way as you told me.
Yeah.
Okay. So I bring on.
So spine is
Okay.
here. Yeah.
Spine is here.
Yeah.
I go on like that one.
So spine is not
Yeah,
here.
that-
Yeah. Yeah.
Yeah.
Yeah.
Okay. Bring them on together. Put the fingers back in. I go like this.
No, you don't
And-
need to. No, so if the spine is there, head, legs, okay, you start like that or like that. So spine is there, and then you simply
Turn around.
spine sits here.
Okay.
You don't change anything now; it's there, it stays.
Okay.
Okay, so this T7 is here. If you want T8, you go to the next one. Okay, you don't have to go forward or backwards.
Yeah, but I can't just leave the fingers like that.
You could.
Yeah, because this is how it worked for me and
Yeah,
Tammy.
you could work.
And it didn't work like this.
But it worked flat.
Yeah,
That's fine.
flat on the floor.
It's fine.
It works like that for us, but it doesn't work.
Yeah, yeah.
Maybe,
That's why I said-
maybe my hands on.
Technique 1, 2, 3, 4, or 5. Yeah,
Yes,
it's
yeah.
fine.
Thank you.
That's
No
what I
worries.
have to. Because as soon as I do that,
You do it to your knuckles, is it?
yeah. As soon as I do that, and the weight, body weight goes on that. That's it. Just
That's it.
like,
I know you're out.
For us, doesn't
Yeah,
work.
that's fine. You have to
For
adapt.
me, it's working this way.
Perfect.
Perfect.
Well done.
Thank you.
No problem. That's it. That was it. Yeah, that's it.
Yeah.
Just watch his knuckles, okay? Because it'll be sore.
Yeah, they
You have to get them trained, flatten them.
yeah, it's
Yeah.
tough.
Yeah, yeah. Or you put something in between and squeeze it. Okay, so then the pressure goes onto the sponge bit rather than your knuckles. Yeah. That's what every story. So now we get into a little bit more complex on manipulation. You know, the one with the towel is quite easy. Now with these, it starts to add in another dimension. Yeah. Yeah. Sorry. So spine. Yeah. So spine is parallel. And then from there, you can rotate your hand. So now the spine sits in here. Yeah.
Yep.
Okay. Roll them onto your hand and see how it feels for both of you. Yeah. Flex them down to the level. Okay. Use his arms to flex them down because obviously your hand is here. So you have to flex them down. Take a breath in. And then your body weight is over. So your body weight is coming through the arm rather than just your hand thrusting.
Right.
So you're going to drop your weight through.
So deep breath in.
Okay. But more rather than use his arm, just use your body weight to go through.
Okay. Deep breath in.
Just watch your elbows and your chest now off that one. Okay.
that's good, Wendy.
So,
Can I just show? Can I just show you again? Like Callum and Costin trying it on the floor, which is fine. Laura, can you have a line in the back?
What, sorry?
Line in the back, please. So let me just show you again. Like some of them, the first few is quite easy, okay? Like this one, especially the lumbar one, which we're doing shortly, okay? There's quite a few little dimensions too. Now, whereas this one, watch again. Some of you with the hand positioning is fine, okay? So technique number 1, number 2, number 3, okay? Number 4, number 5. And then obviously you can squeeze with a sponge. Like for you, it works flat. It doesn't work for me. Yeah, I'd struggle to manipulate with a flat hand, but if it works for you, it works for you. Yeah, some of you are doing it that way, it's working. Yeah, some of you are following my way and it's working. For some, it's not working, okay, because it's irritating your knuckles. And that's just the way it is. I said half you will struggle. Yeah, not because it's the struggle with a technique. You struggle with the position of your hand. Okay, you've played basketball and you damage your fingers. Okay, or you play tennis or wherever, you know, hockey or, you know what I mean, okay. So you just, they don't flex like they used to. Yeah. So when you're doing it, so from here, I'll show you, but I'll do it in a motion, okay? Rather than 1, 2, 3, I'll just follow through with it in one swoop. Breathe in, breathe out. Okay, but no release on that one. Okay, surprisingly. Yeah, but I would do it in one movement rather than some of you, I'd like to say, setting up here, and then you're there, and you're trying to do this, okay? Yeah, but if you see the way I'm doing it, I'll do a flat hand fist technique. Breathe in. As you breathe out, I'm rolling, I'm flexing, I'm locking, and I'm thrusting as a continuation. Yeah, rather than you place your hand onto your hand, thrust through. Did you want another practice or we move on? One more practice? Yeah. Yeah. So just try a few minutes. Yeah. You're a bit stiff.
Yeah, it is.
Yeah.
This one.
Which one?
This, like, so what's next?
Ribs.
Ribs?
Springing.
Oh, that one?
Yeah. Yeah. Butterfly. Yeah. Huh? You do it, you said?
Do you not do, well, I do, no, I don't do thrusts.
Well, on my advanced, I'll show you obviously the first one, the spring, which is I show in this one. Then I use the pelvis to rotate.
The rotation one I use quite a lot,
Yeah.
like that stabilized
Yeah.
pelvis and rotate.
And I do the triangle on the upper back.
Yes, I do that.
I also do a first and second rib.
Yeah, they're quite easy to do.
Well, yeah. Yeah.
That's too much. That's too much hassle.
So I use you
Do you want to use me?
for the rib one. Do you get some releases on your ribs?
I'm going to get you to just crack me
Okay.
later.
All right. Okay.
Neck,
I know your neck.
no, I would probably wouldn't do this. It's too
far for me. I need to talk to Lynn to be good at it. I'm not very good at it.
Yeah. What about ribs? Do you think I'll get much release when I push on your ribs? Yeah. For the demo.
Yes.
Huh?
Yes. Yes. Do my hypnotic
Yeah.
Back.
Do back after if it's.
Yeah.
Okay.
And nobody's watching.
Why?
As I go.
Yeah. This couch. Yeah.
Just so that I get you.
Yeah. Okay, next one. Okay. So let's say, for instance, we've got head and legs. Now, obviously, ribs T1 to T12. On a course not so long back, as I taught this technique, one chap in the corner said, "Can you manipulate the ribs in the lumbar?" And then no one said anything apart from I giggled. And he said, "Well, can you?" And someone said, "There's no ribs in the lumbar." And he went, "Ain't there?" And I was like, "Are you on the right course?" Yeah. It did make me smile though. Yeah. So, but there's no ribs unless it's an anomaly. All right. You know, you might have one. I don't know. So head. So when you palpate in the spinous process, it's not going to be like this. But as an example, if you palpate down and you notice one spinous process is drifting, let's say over to the right side, which way is that vertebra rotated, right or left? Left. Okay. Yeah. So even though the spinous process is going to the right, the vertebra is rotated to the left. So the TP on the left will be shallow compared to the TP on the right that will be deep. So one technique, pisiform, close in, breathe out, thrust on this hand only.
John, can I just ask?
Yeah.
How you said there about the spinous process has gone for a wander over.
Yeah, to the
there,
right. Yeah.
To the right.
So but the TP is prominent on the left.
Okay, so but that's not it. That's not the spinous process having done that.
No, it's just, well. Okay, so that's a vertebra there. Okay, like that.
Yeah.
That's L5. Okay, so if the SP is going that way, okay, then the vertebra has rotated to the left, but the SP is going to the right. But it's only.
So it's like a slip.
Well, not really. It's rotated. It's not really translated. It's rotated. Okay. So the vertebral body is rotated to the left.
Yes.
Yeah. So the TP on this side is more shallow,
Yes.
and this side is more deep.
Yes.
Yeah. So you could use that TP with a heel hand and push it back. Yeah.
Okay.
Yeah. So that's one way. So if you have your hands close to the transverse process, as in the spinous processes, it's going to affect the T-spine. This one is more for the angle of the rib. So where the transverse process is located, the rib articulates with. So it's called costo-transverse junction. The rib continues to attach to the vertebral body, so it's called the costo-vertebral junction. They're not true facets, they are demi-facet, which is like a half facet. When you breathe, you got two types of mechanism for breathing. Okay, pump handle, bucket handle. You got this type of motion and this type of motion. All right. Now, when we come on to mobilizing the rib, let's say the patient perceives a rib dysfunction. So things like coughing, sneezing, breathing, laughing will hurt. Yep. That's what they will say. My rowers of Oxford, they were very prone to having a stress fracture on that sort of like mid-rib, around 5 or 6, give or take area. It was mainly because of a serratus anterior attachment. So they row in 2 times, 3 times a day, okay? Always training 90 minutes on a rower. Okay, so that constant, but have a sweep side or bow side row in. Okay, so that's engagement of a serratus and a stress fracture. So the test would be for that rower, they lay in the back and I just say, just sit up, Okay, or if I make him laugh, they're like, oh, stop it, it's hurting. And that's normally signs that he probably got a rib fracture. Okay, because he's like, oh God, that's really sore. Okay, and movements and sitting up. Sitting up is normally the test. Just sit up. Is it painful? You got a stress fracture? Probably. The thing is, with Oxford, you can get a bone scan the next day. Okay, because we have a GP link, and it's just send them off and we can have it done. They bypass all the waiting lists and just get in. So it's quite easy that way. Now, hands are wider, so the angle of the rib is over here. So let's say this is your patient. Head, legs, hand, hand. Okay, so not close, wide up. They breathe in, your hands raise. They breathe out, your hands fall. Breathe in, and as they breathe out, look at my hands. I either can rotate this way, okay, this way, and then I slowly spring. How much do I spring? Feel the depth of the wood of the couch, and that's probably about correct. So when you push, that'll be about right, okay? Push. Some of them are deeper than others, but you push and spring it. Hands up and hands down, okay? So breathe in, always on the out breath. So that would be a spring technique known as a butterfly spring. It's very borderline between the grid 4 and the grid 5. Is it a minute? Is it not? If you're not really thrusting, it's a grid 4. If you're thrusting, it's a grid 5, okay? Or it's a HVT or an adjustment. So it's very fine line. And also on the spring, you might get cavitations, okay? So it's already clicking without doing that much. You use it as an assessment, but you can use it as a treatment. Let's use this lady, please. Face down, if you don't mind.
That way?
Yep. It is quite nice. Let me just show you a few things here, okay? Because rather than just doing it, which can be quite aggressive, if you've been massaging with oils and creams and waxes, your hands are going to be slipping all over the place. So I have a t-shirt on or towel over. Yeah. If they come in and if they just want an adjustment to that back, I still suggest you warm them up first. Doesn't matter what you use, machine, thumpers. You got two hands, okay? Towel over. Literally just rock the lower back. Palpate the spinous processes. You can almost use it as a motion detector. Yeah, around there. It's quite relaxing, quite relieving, to a point. A lot of people, when I watch them do this technique, they're almost too aggressive. And if the patient doesn't like it, watch the difference, okay? Okay? They won't like it. Okay? They won't like it. Okay? So just use momentum. Almost like push and let go. Okay? So you push, a little bit of pull in, but so it's more relaxing. So this is doing, this is feeling. Okay? Around there. But this technique is nice because from here, you continue into heel hand away from you on the spine. Okay? When I say spine, I'm on the lateral side of the spine, on the soft tissues. So it's all stimulative. Between T1 and L1-2, what nervous system is it mainly? Obviously, it's all the nervous system if you look at the central, but I'm looking at it from just a T1 to an L2. What is it? If I said S for stress, SSS, sympathetic. Okay, so the sympathetic is the stress response level. The parasympathetic, which is the vagus nerve, cranial nerve 10, okay, and then the parasympathetic outflow from the sacrum from S2 to S4 calms you down. So if this area of the spine is very stiff and rigid and you are stressed, okay, because you're worried about A, B, and C, and D, and E, okay, then all this area is going to feel quite tight and quite stiff. The muscle is going to be in contracture all the time. The hair follicles and the sebaceous glands are going to be working in a different way to where it should. The skin is dry and pimply and irritated. Okay, it's called trophic changes. So if you look between this area and you're quite dry and scaly, it's because you're just on a constant stress all the time. By doing this technique and controlling your breathing, you're trying to get the parasympathetic to be active to calm you down a little bit. Okay, so it's almost like preparing that area. Okay, especially when you breathe in and breathe out and breathe in and breathe out. So from here, just do the other side and slowly just have a go at gently mobilizing. Coming through. It's all quite nice, okay? From there. I've even had patients where they almost have chronic fatigue syndrome, where they're almost like so down in the dumps, how they feel. But by doing stimulation to the thoracic spine, you can almost give them a little bit of a boost because you're almost stimulating the sympathetic system as well. Okay, around there, because the sympathetic ganglia is very close to the vertebral column, okay, the spine. Now, so from there, so you can just change in angles, and it's quite nice just to work around that sort of rib cage. And as you feel it, you can feel, you know, it's a bit of stiffness just in this sort of mid-thoracic area in here. This right side more than most. Now, let's take it another stage. So from here, take a breath in, please. On the out breath, okay? As she breathes out, we rotate, breathe out, and then we start springing. This is not manip. This is springing. Take a breath in and breathe out. Okay? And that works quite nicely. For some, you will be cavitating. Now, I am just going to go into a little bit of a pressure to a cavitation. So watch the difference. It doesn't look that much different, but you'll see a definitive thrust here, okay? Take a breath, please. And as she breathes out, I push as she's breathing out. Spring, 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 thrust. Okay? Nice little releases in there, okay? Yeah. When I watch people do it, they're too aggressive. Okay, because it's uncomfortable for the patient, but they don't do it in a controlled way. As soon as they come on, it's a okay, and the patient is just reacting and just tightens up, and they feel worse for it. You have to do it controlled, and I'll make it look quite easy. Okay, and it feels quite nice. Hopefully, take a breath in, relax, breathe out, spring, 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 thrust. Okay, so the body's prepared for what's going to come next, rather than a sudden shock to it. One little thing you can do, on my advanced course I show a lot more on this one, but one technique I quite like, almost, excuse me where my hand is here, okay? You're going to come towards the anterior part of your hip on the ASIS in here. And what's quite nice is if you pull and you push, you counter rotate. Okay, quite nice for the lumbar. And even sometimes you pull and you push and you just wait a few seconds and just pulse a little bit. Okay, take a breath in. And as I breathe out deeply, immobilize on the out breath. Okay, sometimes you can use a thrust for that if you wanted to. And the angle of thrust is towards the axilla, okay, towards the armpit. Yeah, around that sort of area. You might see in chiropractic YouTubes, yeah, where they come using this one over here, and I use this as a spring. No real different from coming over this way with my hands from that way. And no real difference is coming this way using that angle. Okay, so, you know, there's a few variations. I don't want to show you too much because a lot of people will forget. Yeah, you know, which one did you show us? Oh, God, I can't remember that one. Yeah, and then there's another one, and there's another one. So almost like keep it simple. So towel, rock, use the breath in and the breath out. Breathe in, and as she breathes out, you just mobilize in the tissues, walk around, do the same the other side. Breathe in, breathe out, rotate, just a bit of spring in. So you ascertain motion in the thoracic spine, okay, and also the rib cage. Coming through in there. Take the next stage, breathe in, breathe out, a bit more pressure, a bit more spring in. I must admit, those ribs in that lumbar feel stiff. Someone gets it.
I just had a head replacement, didn't I?
I know, you're good. Good. Any questions on that? A lot of people use that technique. You know, I used to teach my sports massage therapists in Twickenham, and I would probably show them that technique. Yeah, because it is quite nice. Makes them feel quite tired. Yeah. Yeah. All right.
Grand.
Feel okay? Good. Have a go.
It's balance me out.
Okay. Yeah, no, you're a bit stiff now, yeah. I thought you might have released one just on a spring in, but then you just needed a little teaser one. Yeah. Bend.
Breathe it, yeah.
And ease off. Breathe in. Breathe out. Yeah, and then a little bit of a...
Yeah. Yeah.
Yeah,
Just like-
okay.
Okay.
Yeah. Just try, that's fine. If you want more to affect the angle of a rib, over towards the axilla. And try it on the out breath. Karen, breathe in.
Yeah.
Or Wendy. And breathe out. Okay? Yeah. Well done. That's good. Try it on the out breath. Breathe in. And as she breathes out, you've got piano hands, you have.
Yeah.
Piano fingers.
Yeah.
Yeah. Do you play piano?
No,
All right.
not very well.
Maybe you should. Yeah. Where do you live?
Mulgai.
Where?
Up at Glasgow. North
Oh, I was in Glasgow.
Yeah.
All right. What do you call it?
Mulgai.
Milgai.
Yeah.
Okay.
So they say Mulgavi on the train.
All right. Okay.
That's how they pronounce
So it's not far then for you, is it?
Oh, no, not at all.
That's great. Yeah, 'cause a lot of people from Aberdeen here. Stranraer, Travel, and Manchester.
I was gonna
A lady
ask
yesterday was from Dublin.
Would you ever want to do any courses at Hampden Sports
What?
Clinic? Hampden, the National Football Stadium?
Yeah, of course. Yeah. Was a football stadium, is it?
Yeah,
Okay.
yeah.
Hampden.
Yeah.
Is that where you work?
That's where I work, yeah. We've got a sports clinic, so
Yeah.
physiotherapists and...
Yeah, that's right. Well, I teach in my law clinic, so yeah, it's fine. Yeah, so you got my details,
Yeah.
my email, just send me a message, it'll be fine. No worries. Yeah. Oh, you there? Did you come down? Yeah. Yeah, it was a busy course, wasn't it? It's just ridiculous. Yeah.
Very busy, that one.
I didn't realize, I thought I was going to do a little bit of teaching, not realizing it was like a John Gibbons sort of like convention for 4 days,
yeah.
and then, yeah.
Yeah, that was intense.
And she put me up in a little travel lodge. It's like, can you say something nicer?
I know,
Yeah.
I know, it would have been better if it was a bit nicer. Not much up there either.
No. Good. Remember on the out breath, yeah? So we feel okay? All right, good. Try and do it rather than watching, okay? Take a breath in. And as she breathes out, breathe out, breathe out, breathe out, breathe out, spring. Then you can do a little thrust, okay?
Okay.
You all right? Yeah.
So breathe in, breathe out, and then in the end of
Yeah, so maybe open your fingers a bit. Yeah. Breathe in, breathe out. Breathe out. And just spring more. Yeah, that's it. Okay. Not everybody would like the pressure, but sometimes if you want to change it, you just have to just use a little bit, okay? Without irritating if you can help it. But, that's good, Doug. Just change the angle of the hand a little bit towards the axilla. Okay, and try it on the out breath. Take a breath in, Adrian. And as he breathes out, you pull and you spring there. Yeah, that's it, on the out breath.
Spin your right round.
Was it?
Send me a book.
Yeah? Which one do you want?
Sure. Sign.
Yep. Okay, sign it. It's normally 25, I would say 20.
Okay, thank you.
I would say 18. To probably keep in with Amazon because Amazon changes the price every few days.
Did they really?
Off, without a doubt. Yeah, yeah. You might see it as 22, then it might be 19, then it might be 25, then it might be 17, then it might be. Just doesn't end. I'll sign it for you. Have you?
Oh, no. Any future plans for coming up again?
Yeah,
Just keep watching the website.
a bit thick this pen, but I won't close it yet.
Kind of, yeah.
Yeah, maybe don't let it touch yet until it dries a bit. Yeah, but it'll be okay. No worries, Mark. Not the same with mask below, does it? Should have took it off. Have it on full, you take it off. I know. Yeah.
Just 2-year-old John.
Yeah. All good?
Yes, all good.
Amazingly, by treatment of the thoracic spine, it can make your lower back feel slightly better.
Yes.
It could.
Yeah.
Not always, but it can.
Yeah. I feel I've always got kind of a pain.
Yeah. And you have an adjustment twice a week on the lumbar.
Yeah.
Wow.
Well, I've gone from permanent pain level of 6.
Yeah.
Mesh rugby, philosophy.
Oh yeah, you said, didn't you, when you was in the mess?
So
Yeah. Mess rugby.
yeah.
I remember you saying.
So permanent pain of 6, when it flares up, maybe 8.
Yeah.
And I've gone down to pain level of about 2.
Okay. That's good, isn't it? Yeah. Well,
Um,
like in the morning when you wake up, it's a bit stiff, or is it okay?
well,
Not so bad.
beforehand, until I started on the plan, I couldn't go down the stairs.
All right, okay.
So I had to virtually do.
Yeah. And you work in the clinic anyway, yeah? Chiropractic?
Yeah.
Yeah.
So I can all. That's
Yeah.
why I'm getting all
Okay.
free.
And they adjust you okay? They don't cause any? And they get cavitation from your lower?
Yes, except my TL. My TL still solid at the moment.
Okay. How do they normally do that? Rotation, lumbar?
He's done.
Yeah, it's not so easy, on TL.
No, at the moment we seem to be getting more results with blocks.
All right, okay.
You know, so and that seems to be easing it or moving it a wee bit more.
Yeah.
But we left the TL because we thought doing C-spine and lumbar and sacrum, that might just actually start to
Yeah.
doing TL.
Okay.
But
Yeah.
it's,
But sometimes the thoracic lumbar doesn't need adjustment because it's like the transitional between thoracic and lumbar.
yeah.
So sometimes it's irritated anyway.
But obviously, because we get medicals every year,
Yeah.
military, I've gone in the last 3 years, I've lost 4.5 centimeters
In what?
because of my posture.
1 height? 4 not? Wow.
And
That's almost 2 inches, isn't it?
yeah,
Oh.
so I've gone from 173 down to 168.5. But 4 weeks after I started getting adjustments,
You're getting taller?
I've got a centimetre and a half back.
I need some.
Yeah, but I lost it, John. I've just found it
Okay.
again.
Yeah, okay.
Yeah, I mean, I'm overly impressed because I've had a couple of different chiropractors.
Yeah.
One of them was very similar to what you were talking about, conveyor belt.
Yeah.
This one, they won't touch you unless you've had the full hours consultation with
Oh, wow, okay.
the full
That's brilliant.
well-being check.
Yeah.
And we've got the in-body machines and all the rest of it.
Yeah.
And yeah, brilliant. Independent little rooms, go into a room,
Yeah.
sit down with your.
Yeah.
So it's good. But because it's the way that we work, we've got the Chiro, we've got MSK, and we've got the rehab as well. So
Okay.
My husband does the sports rehab stuff.
Yeah.
So and it's a cross referral.
Oh, okay.
Yeah. So
Sounds
it's not
good.
often I get somebody walking in just for massage. It's
No.
not the old cross, so you're getting injuries,
Yeah.
which is good.
Okay.
Yeah.
Cool.
Mm.
Okay, can I move on in a sec? So we're going to be doing the lumbar one next. SJ, do you want me to use you? Oh, no.
For me, with my head,
Yeah.
the biggest pain output was
Okay. But wait a minute.
Come on.
Huh? Wait till it dries. We're not going to be lying that way. Huh?
But where am I going to be lying?
Head.
Heads.
Yeah.
Sorry?
Do you have a pillow or not?
Can I use the towel?
Do you have a pillow? What's that?
Can I use the towel?
Yeah. I've had liquid nitrogen there last week, 186 degrees to burn. I had some cancer cells, skin cancer, BCCs. So it's called basal cell carcinoma. I had loads of cut out, and they decided to use liquid nitrogen to burn them off. I went, it's going to be sore. A little bit.
Sore?
Oh, it's okay.
Snippy.
So, yeah. Now, where's that towel? You got a towel? Because that's a bit cold. This is called the lumbar roll, and is probably one of the most common techniques the osteopath, even the physio, but more the chiropractor would use. Chiropractor in a different way. They might use like a drop couch, use blocks, yeah, and things like that. The technique tends to be more body weight drop-in, yeah, that sort of thing. The nickname for the technique, any ideas what the nickname is? Think about how much money is made from one technique, okay, throughout the world. So they call it the $1 million roll. Okay? They do say, what's the difference between a chiropractor and an osteopath? Do you know what the old saying is? About 100 grand. Yeah, that's what they would normally would say. Okay, so if you want to make maybe a lot of money, then potentially consider the chiropractic field. You know, it depends what your ambitions are and things like that. So, whereas I'm just a poor osteopath. So, yeah. Well, I don't really treat many patients now. So, do you want on your side? Yeah, I prefer to be on the dirt on my dirt bike more often.
Side.
Yeah, towards me. Towards me. So the lumbar roll. Let's say, for instance, it's quite easy in some ways. It's either an L4-5 or an L5-S1. You can obviously manipulate L3-4, L2-3, L1-2. But most of the time, it's going to be an L4-5 is the issue. If it's L4-5, then it's going to affect the exiting nerve root of L4 because it's below. So L4 symptoms might be that the dorsiflexion. Is that on? Is that on? Is it?
What?
Is that playing?
Are you fine?
Okay. So the dorsiflexion of the ankle is an L4 nerve innervation. If it's an L5 nerve root, you might have weakness on the great toe extension, so EHL, so extensor hallucis longus. And if it's an L5-S1 affecting the S1 nerve root, because on my, a lot of people get confused by this, because if this is the L5-S1 disc, for example, okay, this would be the L5 nerve root that comes out. But the disc prolapse, okay, a disc prolapse might not touch the nerve that comes out. You can see in this case, it touches the nerve that goes down. All right? So a disc prolapse here is contacting this nerve root. Okay, so an L5-S1 disc, the L5 exits and the S1 descends. So normally a prolapse at L5-S1 doesn't touch the nerve coming out unless it's a large prolapse. It touches the one going down. Why? Because this is the chorda equina. This would not happen in the cervical spine, because if I was C4 and C5, it would only touch the C5 nerve root, because there's no tail of the horse, okay, the chorda equina. Okay, so potentially you could have a prolapse higher up, around L1-2, which is quite rare, but you could, okay, touching the S1 nerve root. So typically in the cervical spine, you might say, I believe it's a C4-5 disc touching the C5 nerve root. Whereas in lumbar, you might not say that. You say, I suspect it's a disc prolapse contacting the S1 nerve root. You might not say it's the L5-S1. All right? Yeah, because you think the disc prolapse is higher than what you believe it to be. Okay? Because of the way I'm explaining. Now, if you decide to manipulate... Is it on the phone, is it?
Sorry, it's just like...
Yeah. So when we set up, I'll show you there's many ways, okay? You know, I can show you 4, 5, 6, 10 different ways of mobilizing lumbar. So if I show you the set way and learn it well, okay, once you've done it lots of times, at least say 20, 30, 400, okay, then think, is it working or not? Okay, don't keep changing it because you don't know where you're going to change it to. So keep it simple in some ways. The foot in the crease of the knee. The lower leg, okay, the bottom leg, a little bit of flexion because it initiates flexion from below. So this would be the starting point. If you start, you know, if you're reading books saying, well, this is an L5 and that's an L4 and that's an S1 and that's a, don't worry about it, okay? Just keep it simple to start with, okay? Otherwise, it's too much to think about. Now, the top hand, like here, doesn't really do anything. Now, when we do this one, I'm going to hold your upper arm, okay?
Mm-hmm.
So what we're going to do is palpate the lower lumbar. The iliac crest will be in line with what? L4. The PSIS will be in line with what? S2. Okay, so if you come onto the crest to L4, okay, and you want to manipulate L4, L5, lightly palpate the level above and look at my hand. Okay, so I'm going to rotate my patient down to the level there. If it's the one below, I'll pull a little bit more. So rather than just rotating them and hoping for the best, try to focus on the rotation to the level, okay? Now from here, hold on to the wrist, and then the neck I'm going to get you to look up, okay? So these are the setup points here. There's more to think about now. Now, this is your space. Arm through, and then from there, what we're going to do is we are going to roll the patient towards you as if they're going to fall off. You have a choice. If I've got like my rugby player and he's 20 stone, this be different to my female patient who's 8 stone. Okay, yeah, so sometimes I might have to get them to help me a little bit. So I can bring my patient over as if she's almost going to fall off the edge. Okay, if you're not sure, my knee is in her knee, and I'm going to use my body just to guide her off the couch here, okay? Are we okay? Mm-hmm. Yeah. Now, so this is the position. Couch is a bit lower. So roll them as if they're going to fall off the edge of the couch. So this is where we are. So this is going to be an L4, 5. Get your body weight over the patient, okay? You don't have to have a knee in there if you don't want to. You can just body weight. You're going to come up and over. Over, see? So I'm using my body weight to come down through. This technique in itself is already a mobilization because I'm using my body weight towards the femur in a side bending plane, not rotation, even though it looks like. Okay, and I'm just using my body weight rather than my arm. Half of you, okay, will use your arm to do this, and they won't like it. Half of you will use the elbow in a piriformis, and they won't like it. Okay, try get your body weight over so the weight is pushing through the flatness of your forearm in here. Okay, so your body weight is down. Watch now. Okay, so I'm just going to mobilize, going down, mobilize, 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 mobilize from there. Okay, so that's a mobilization technique. Very close to a minute, but not quite. Now, if you want to use the knee, you can. You don't have to. It's called the Kickstart Technique. So I'm going to get my body weight. It'll be interesting to see what happens with her. I'm not convinced she's going to cavitate that well, but we're going to try. Take a small breath. I don't want to force. Breathe out. From there. So my body weight is over. Thrust. All right. Okay, yeah. So there's a little release, but not the loudest one. Yeah, around a sort of area. And what I don't want to do is to show too much force, because you see me force in. Okay.
So in her case, would her right side have been the shallow side?
The right side, yes, from in terms of palpation, then the right side would have been the shallow side. So the dysfunction side would have been up. Yeah, so the dysfunction side up. So if I was to palpate like what we did this morning, yeah, So the thumbs would be on. I might show you that after, yeah, if I get a chance. What I'm going to do is just show you from the other side. Yeah, so let's go the other side. But you're going to put your head this way, this way. Yeah. So I'm going to set it up a little bit quicker. And I might actually show you on somebody else as well. Yeah, or maybe I'll let you have a practice, then I might show you again. Okay? Yeah, so from here, from there. So this is my setup. Lower leg flexion, top leg, the foot in the crease of the knee. Hand to counterbalance the stability in here. Let's say I'm going to do L5 S1, okay? So I'm going to palpate iliac crest, L4, go down to 5. So I'm going to come down, and I'm going to rotate my patient down to the level, hand onto the wrist, stabilize, 5. Roll as if you're going to fall. They almost feel like they're going to fall off.
So you're the spinous process of L5.
Yeah, but that's not really doing anything here. This is just feeling the spinous process. Yeah, over and here. If you're not sure, you can use the knee over here, and I will help you. The pressure is going to go through the femur, the forearm. Okay, so from there, the body weight's going to be over, and you're going to spring through. Yeah. So that in itself, for some, will cavitate because you're springing down through there, and the pressure is not really through the top of the glute piriformis, because the pressure is coming from my body through the flatness of my forearm, rather than from an elbow that's going to dig in. Okay, and it's not very nice. They will probably react to that. So the key is, so it's almost like 3 things. You roll as if you're going to fall. The body weight is up, 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 and over. And then the technique will be through the femur. Okay, from there. So take a small breath. And then the thrust will be over from there, lock, and the thrust is a thrust through. I'm probably going to show you in somebody else in a second. Yeah, because I can feel like I'm going to need to put a bit more effort.
Got a little bit of cavity, but yeah.
Mm.
And it's stiff.
She is stiff. Okay. Yeah, but I'll show you when somebody.
Really stiff.
Huh? Who should we try? Karen. Yeah. Yeah.
Would the lesion be on the downside?
Lesion be on the upside. Dysfunction side up. Yeah. So the shallow side is up. Okay. So if the right side, so it's ERS right side up. ERS left side up. But okay, when you think about it though, when you see the osteopath or chiropractor, how often, if not every time, would they do both sides? Okay? They do both sides. Okay, so thing is, as you open in the top, what you're doing to the bottom. Okay, so you're closing the bottom one. Okay? Yeah, so I'm using my knee this time. So it's L4. I haven't really assessed you. Take a small breath, you okay? There you go. Just went. Breathe in. Breathe out. On there. Body weight over. Good? Okay?
Yeah.
Yeah. Let's just go that side. Or shall I leave it for somebody else? Yeah. Well, I'll leave it for somebody else. Okay, so that cavitated quite nicely. Yeah? 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 Yeah. But have a go over setting up the rotation. Yeah, and then have a little play, see how we get on, and I'll show it to you again. Yeah, and then we'll see how we get on. Good. Yeah. You are stiff.
Oh, no. Think about what I've been through.
Yeah. Yeah, I thought you were going to be quite mobile, I did. I thought you'll just be like flapping in the wind. Yeah, no, yeah.
Then on my left side, when I'm lying on it, just because.
Yeah. What I sometimes like for the demo is that as I lean, I think it's the pressure on the top of the glute is what she's feeling.
What's that film when the guy goes through a ton of shit? What's the guy's name?
What type of shit? Yeah, watch his couch because he's
Yeah, I know.
yeah. To stabilize him, you could put your knee on his knee
Yeah,
because his couch is dropping there.
Yeah.
What's it dropping now?
I think it's just the weight.
Just the weight of it.
It's not
Yeah.
about.
Okay, well I'll sit on this edge as you do it. That should be alright.
Okay, take it back in. Breathe out.
The thrust is weird.
The thrust,
Where are we going?
you were trying to rely on you because you'd be strong. You'd rely on your strength to do that. But what I suggest you do is roll him a bit more. But you have this part of your body wants to be connected over, over more, up, over,
Okay.
no more.
All right, that's it. Yeah.
So your body weight there, more.
Yeah.
Okay, so you're using your body weight
Yep.
to go through the femur.
Yeah.
So you use your body weight to drop through. It's almost like a drop thrust.
All right. Okay. Okay.
Okay, rather than using your arm as a strength.
Take a
Yeah.
breath in. Breathe out.
Not bad. Okay, it's not bad. Yeah.
Contraindications.
Oh, loads.
That's what I mean.
God,
Like,
tons, tons.
How you feeling? You all right?
Yeah.
age.
Age to a point because of spondylosis. All the spinies.
Yeah.
Yeah, to a point. Spondylolysis probably be contraindicated. Life is definitely. Disc pathology debatable. Well, you say that. If they've got acute pain in the leg and it's been there for a while, it's worth trying because you might help it. If it's like a niggly disc and it's been on off, it might make it worse. Yeah. Yeah.
So I've had a partial lumbar discectomy, L5S1,
Yeah.
so I was just going to...
You might be all right.
Sure.
Yeah, because you probably won't force it. Yeah. If you're not sure, just leave it. Try the other side. Yeah. Yeah. But you wouldn't worry, be okay. Well, how long ago?
13 years ago.
Oh, it'll be fine. It'll be fine. Yeah. Yeah. All right. Yeah. That's it. Right. You need to stand up, and you need to get your body weight. Keep your arm flat. You need to get your body weight over. Okay.
Should I put my knee up there as well?
Yeah, try the knee. Okay, so your body weight is over. So your weight is going to go through the forearm. Okay, so you can't manipulate using the strength of your arm. You have to use your body weight to drop down, almost like a drop. Okay. Yeah. Yeah.
You're right.
So like this. I'm sorry.
Can you see what she's? Let me just show you this one. Turn towards me, and then if you just watch this. Okay. So from there. So these are just for simple setups. Let me do it. From there, okay? So the couch is low, which is great. So what you want to try to do is, she's light, so it'd be easy, okay? So you roll, as if she's going to fall, look. Right over. But it's not going to fall. So she's in that position, all right? Now from there, to mobile cavitate, you just get your upper body just over her hip with a forearm. So your body weight has to come right over here, look, right over there. Take a small breath, not going to force. Breathe out. Body weight come down through there. Already clicked. Okay, as I did it. Okay, so your body weight is dropping through. Okay.
Can you watch me, dude?
Yes.
Make sure because I'm not sure I'm quite right.
Yeah. Is your accent Irish? Is your
Hi.
you're from Derry?
Yeah, I'm from
Okay.
Derry.
As you say, because I asked this morning.
Yeah, I did the level. Yeah, there's
With
another
Megan.
guy
With Megan.
from Wexford as well.
All right.
Yeah.
Okay.
But he lives in Manchester.
Yeah, as you say, yeah.
We're
You
all
can,
everywhere.
yeah.
Irish way. As opposed to.
Yeah. So when you
Extended.
pull in, hold the upper arm,
Mhm.
so you don't stretch your skin
Right,
and
okay.
irritate it. Okay, so you cradle and then you slowly pull
Mhm.
until you feel it down to the fingers. You're probably already there anyway.
There.
Yeah. And then now she's on to wrist,
the difference.
arm through. Now from here, just have a go at just teasing her to roll. Okay. Yeah. She just rolled in a
Okay.
little bit.
You
Yeah?
don't look at me.
She feels like she's going to fall, but she won't. Okay. Now
This is a trust fall
yeah,
earlier.
so from there, yeah, I know the couch is a bit light this one.
Yeah.
Now, nothing's going to happen where you are because what you need to do you need to almost like support her by leaning your body weight over your arm. And then the movement's going to come through there.
Yep.
Okay, so you use your body weight to go through rather than using an arm, okay? Yeah?
Yep. So that
Okay.
is breathe in. And out.
Not bad, but maybe just a little bit more. Yeah? Yeah?
One of us is going to end up apart.
Yeah, turn towards me.
You're tired.
Yeah?
I'm so tired. You can't fire. John will learn to be fine.
It's from there.
He needs a personal assistant.
Okay, so watch. Okay, so I'm gonna roll. So I'm using my knee a little bit. So just over. So because I'm almost like stabilizing the upper body.
Right, okay.
She's
So
got, she's,
in and down,
yeah, she's got mobile. I'll take a small breath and breathe out. I can just tease her. Lock, lock, lock. Thrust, lock, lock. Oh, she's not gonna release on that.
She's really tight.
Yeah.
It's
No,
always your SI.
she's actually quite mobile in that lumbar. You move quite well. You move quite well in your lumbar. There's a spring in. No, I'm sure you don't. Yeah. Yeah.
I feel like I'm on. So when I'm all set up, right, so we're a bit untidy,
Yeah.
right? And I'm down coming off,
That's it.
got me L5, right, so I can
That's it.
coming off, we're in the diagonal, we're all set up.
So you're gonna roll as if you're gonna fall.
Yeah.
And then you want to get your body weight over. That's it. So your body weight is going to go through the hip. Through the hip.
So don't you feel it was on the, you feel it on the grade?
Well, she will, but then you but flatten the forearm.
Yeah.
Okay. And then rather than pushing with the arm, use your body weight to go through.
So
Okay.
breathe in and out.
Okay. Can I just show you this one again? Yeah. Wendy, can I use it? Okay. Probably there was too much on the arm in his chest. Yeah. So you almost like sprung his chest rather than mobilize his pelvis. Have a lie on your side, please. Okay. If you were running through like an assessment, have a lie on your face down. I might have to take your glasses. If it, no, just leave it trying. Leave them. Just leave them. Yeah. So let's say, for instance, excuse me doing this, okay? You okay? Yeah. Okay, so if you found a PSI as to S2, and then you go into S1, which is where my thumb is, okay? So you got S1 in that LS junction there. So just below my finger is S1, and just above it is L5, so it'll be L5, S1, and L4 will be above that. So let's say L5, S1 is where you think there's a problem. Bring your thumbs lateral, and let the thumb sink. Right side relatively shallow, left side relatively deep, okay? If you come up onto your elbows like you're reading a book, please. The difficulty now you've got is the erector sometimes contracts and it gives you a false positive. So if the tissue is able just to calm and relax as you're there, and you palpate, the thing is the right side erector is just fired up a little bit, so it's not allowing my thumb to sink in. But let's say for the demo, my thumb has become relatively level here. Okay, lay back down again. And then if you rotate your pelvis this way, okay, so now she's in flexion in the lumbar, and the right side is still shallow, then the right side is closed. Okay, so right side will be up, so dysfunction side up. There's also, you can do motion testing as well if you want to. From there, if you have a line your side towards me now, it's up to you if you want to put these on or put your head this way. So head this way. Yeah. So let's say right side dysfunction. So right side up. Right side up, yeah. Okay. So let's say the right side L5S1 doesn't want to open. So we will initiate an opening from there. So from there, from here, palpate, PSI, S1, well, S2, then S1. Come to L4, and then just rotate down. From here, arm through. Don't have to worry so much about the neck because you're not going to irritate it. But some people will use the arm, like here, to force into the ribs. Leave it alone. Okay, so the key now, you're not going to be able to do anything from here. You have to get roll as if she's going to fall off the edge. Okay, you have to just let her just roll off a little bit and just stabilize that lower vertebra. If you want to use the knee, you can. It doesn't really matter. And then from here, look now, okay, I want to get my body weight Right over. Look how over I am. Okay. And I'm mobilizing through here. Take a small breath. I'm not going to force. Breathe out. There's the mob. Bust. And it went click right under my thumb. Okay. And it was hardly any effort. And that's what I wanted to really show you. I want to show you that I could almost like position, fine tune, breathe in, drop, click, done. Yeah, with no force. Yeah. Okay. All right?
Yeah.
Yeah. And how she didn't feel the forearm digging in. It was more my body weight spread out over and drop. Okay, a lot of chiropractors will use your hand over and they'll do this. Yeah, but then you have to use your strength of your arm. And if you're a big guy and you're a small person, it's a little unrealistic. Whereas this one, to use your knee to your advantage, body weight. But couch is lower, see? Couch is lower. Means I can come over easier and drop down through. Yeah. Jerry can try again over there.
Yep.
Have a go. So a few minutes and we're going to be moving on. Some to the pelvis ones.
I'm working on the right hand side. So what I did wrong, I used my hands completely wrong. I didn't put my right hand to control the vertebrae. I put my left hand.
Okay.
So
okay.
my central nervous system say, okay. So I move on.
Yeah.
Right. So now I just.
Yeah.
For the other side, I did completely wrong.
Yeah. No worries.
And therefore, I should.
Transverse process is like that.
Yeah.
Could you just shove the transverse process and
Yeah.
be like, go back, please?
Or a spinous process. Do you mean?
Well, either or. I
Yeah,
don't
you
know,
could,
just something
yeah.
to move it off. But, well, so,
Yeah. You could.
like,
Yeah.
we'll see. I can see me
Maybe just mobilize it rather than manipulate it.
And so
just
when
mob.
you're mobilising it, is
Yeah.
it like am I quite firm?
I'm happy
well,
with mobilising.
Mobilize like that way. Yeah. So instead of you just do the same technique, but it's a rocking motion.
On the lumbar.
Yeah. Yeah.
And then so say like it's over here and it's stuck.
You're not really using the thumb to put pressure on the spinous process. Not really.
You're not on the spine. Okay.
You're feeling the spinous process, but you're not really using the thumb to push.
So you're basically just using it on the area as a guide
as
to
a
where
guide.
you're twisting.
Yeah.
Right. So as soon as you feel the twist going into that area, that's
Your hands are freezing. I quite like that, right?
you know.
I quite like that. It's almost like pleasurable, that cold hand. There.
That's ridiculous.
I like it. You don't have to move. You can leave it.
All the time.
Yeah, no, it's good though. Yeah, because my hands are so warm. Look.
When I'm getting
That's
mine
ridiculous.
done, you do
I'm like a hot
feel
water
just
bottle.
about
Yeah, you are.
the bed. Yeah, right on the edge.
I think it's a bit high for you too. But try anyway. Try
Just a
it.
bit.
Yeah.
Right.
Right, what are you going to do from there?
I come under.
Yep.
And effectively squeeze down. And then. So normally, like
Yeah.
here. This way we went.
Yeah.
You come towards.
Not that it's education, I'm sorry.
Yeah.
Can you squish towards me a little bit?
That's it. That's it.
So again, coming around and squeeze my arm.
Good.
Okay.
So you have to roll it quite a lot here, okay, to get her over.
Okay. Where am I? Where am I fixing? Like.
Now you're going to stand up more. Get on your toes.
Okay.
Yeah.
Yeah.
So your body weight's over this forearm. Okay.
Okay.
So your weight's going to go through the arm.
Okay.
Yeah. So you're going to get your weight over there. There.
Okay.
Yeah. And the thrust will be that way. You okay, Kelsey? Yeah. That way. So that's a mob.
Yeah.
And the thrust will be through there.
Okay.
Yeah.
So you literally just about have her off the bed.
Yeah.
Right.
Yes, you have to. So
Okay.
you're using the momentum of her.
You okay?
Yeah. Yeah.
Oh, do you want to try that with me?
Let's try the other couch. Let's try this one.
And
A few minutes, we're going to move on. Yeah, 1 sec. Sorry. Kelsey, just come this side. All right. Okay. So maybe have her a little bit closer to you to start with then. You might find it easier. Okay, she's already there. Okay, so from here, lower, L5. Use your knee if you want to, and just roll, roll. You okay?
Yeah.
Sure? Body weight, come over, and just mobilize, spring from there. And then you can, if you want to, you can thrust through. Okay, all right? Sure? What's the matter? Yeah.
More twisted. Jumping times and go. No, it's fine.
Yeah. Try the other side or
Other side.
yeah.
That's fine. That's fine. That's fine.
Thank you.
Yeah, try that way. All right. All right, I'm just going to go and help. So we're going to go on to a few other things in a sec. Jerry, you wanted me to show you, didn't you? Yeah.
So it's just getting the body weight.
Yeah.
So come here, hook that in.
Yeah. Yes, it's to feel where it's going. Yeah. Couch is probably a bit high for you.
I think so.
Yeah, so that probably would be better. Yeah. It's easier when you have a couch just a bit lower. Yeah, so if you're in doubt, go a bit low.
So it's from here.
Yeah. So use that knee to help to advantage to roll as we fall. Yeah. It does look like you're making it awkward because it's probably a bit too high. Yeah. So like if I swap places with you, yeah, I probably need a bit more rotation for him as well, down to that level. Okay. And there. Turn that way. So I could probably adapt it from this position for me. Okay, but I can come over. See, I can come right over. So I'm right over here, and I can play around with it there, and I can press down. He's stiff, he is. Yeah. I'd probably go a bit lower.
Yeah.
Yeah. You right?
Yeah.
That's good. If you're going to try and lift,
Yeah. Yeah. This is where most people would need the practice on this one. Yeah. Compared to every other technique, it's always this one. Yeah. It's yeah. Yeah. If you came back on a course, you'd be like, oh, can you show me out of all the manips, it'd only be this one. Yeah. Only be this one. Yeah. But it's worth learning because it is the most common technique. Okay, so it's worth learning it well if you can. But when you watch YouTube, it's like, you know, it's different to mine and that's different and that's, yeah. That's it. No, okay. That's good.
so
Yeah.
take over as much as I can.
That's it. So it's, watch your elbow. Yeah. Try to use your body weight over. Yeah. Lisa, is it okay?
Yeah.
Yeah, sure. I say roll more as well. So roll a bit more. Okay. So your body weight is almost right over. That's it.
Okay, breath in.
Yeah.
And out.
Just having that confidence to do that last bit. Do you know what I mean? Yeah.
Rotate. Over.
But you're there.
Breath in. Out.
If you thrust down, nothing happens.
Yeah.
Okay? You have to think about it logically, what it is you're trying to achieve. So the thrust has to be almost like in a side bend at the lumbar to cause the gap. If you thrust just down there, you've got nowhere to go apart from down towards the couch. So the angle has to be, the thrust has to be through the femur.
So almost like a 45.
Yeah, so through the femur to side bend it.
Out.
Maybe just work on that. Yeah, with the,
Do you want to chop off downstairs? Are you sure? Yeah.
Okay, I'm going to move on. Now, do you want to come around, please? You might have to move that one for this technique. No, okay. The leg thrust. If you can't see, come around. This is one of my probably most popular techniques for the pelvis. Now with the pelvis, you know, I do run a 3-day course and we're going to do it in 45 minutes. So it's going to be a bit less than I would normally do. Now, with the pelvis, there's a few things that typically go on. Okay, so it's like a 3-dimensional ball. Lots of things can go on. There's potentially, according to Greenman, 14 different types of dysfunction. You might know a lot of them. You might say an anterior rotation. Okay, typically the right side goes forward. So you have an anterior rotation of the innominate, but then if it goes forward, it can always come back. Okay, so you can rotate in this plane. You can also, what we call a flare in, flare out. Some people believe it, some people don't. But one of the ones we're going to cover first is an up slip. So if the ilium has gone up, Greenman calls it a hip bone shear. It's normally traumatic related or trauma related. It might not have been last week. It might have been last year or 5 years ago. And you've had a niggly sort of back since, where you've fallen off a horse, off something, off a mountain bike, off a step. Okay, yeah, and then you've dropped and the pelvis has been shunted up. You can massage the QL all day, every day. It makes no difference. Okay, so when you are assessment of, then let's say, for instance, you are palpating the top of the crest, iliac crest. You think, oh, one side feels a little higher than the other. When you palpate ischial tuberosity, one side feels higher than the other. Obviously, high in the right, high in the right. Okay, so it's gone up. The PSIS thinks, oh, that looks like it's gone up a little bit. The leg might appear to be shorter on that side. When you look at supine, okay, the ASIS is up on one side. The pubic tubercle is up. So it looks like everything has gone up on that side. So it's shunted up. The QL might be tight on that side. One of the key tests when you sit on a hard surface, like a chair, not chair, like a table, a hard table or bench outside. When you sit, because the ischial tuberosity should be equally left and right contact in the wood, it feels like you're not sitting as level as you could be. So that's one of the key signs, if you like, yeah, or symptoms, what they say. So when you are sitting, you might notice one crest is higher than the other crest. When you lay in prone, again, it's higher, tuberosity is higher. Anybody think they got this going on or not? Come like.
short.
Okay, just have a line in front then, please. So she thinks left shorter. Okay, so as I said, it's normally traumatic related. So if you are palpating this area, then come on to the top of the crest. Okay. Oh, I'm not convinced. You say left? I'm not convinced. Excuse my hands. Excuse my hands. Okay, it's definitely not left. Okay, so if you're looking at my hand, okay. Yeah. It was 50-50. Yeah, but when I'm looking, okay, I'm right eye dominant. Okay, so when I'll always stand this side of the couch. I'll never be that side. I'll always be this side. My right eye dominant will be looking over. So when I'm looking, to me, that right side is higher to me, and the left side is lower. When I come onto visual tuberosity, excuse my hands. Okay, when I come down and up onto it, my right thumb goes higher, but my left thumb stays low. If I come onto the PSIS, my right PSIS hers is higher than the left side. Yeah, you can look at malleolus from here if you want to. It's not so easy, but we can look from there. We would take them off and things like that. So I'd be looking at the right side. If I was palpating QL, not convinced, but the right side maybe just a little bit there. Okay. So I'd be more tempted to do the right side than I would the left side. Okay, which is what I'm going to do, because I believe it looks higher on that side, so it looks like it's been shunted up. Okay.
Yeah, I broke that ankle last year.
Okay. Yeah. Okay. All right. Now, 2 ways of treating. This is also good as well. If you've got disc pathology and you've got, say, buttock pain, leg pain, calf, foot pain, and you don't want to do a rotation like we just done because it might irritate, this one works well because not only is it a correction of the pelvis to bring it down, it's also an opening of the facet. Okay, so also the facet can open, but also the disc, it works on pressure change. By using the leg to pull, the disc works on pressure. Okay, so if you've got an intervertebral disc with the annulus and the nucleus inside, okay, by doing this sort of traction fast, it can cause like a microscopic suction effect. And neuropathy or nerve pain or radiculopathy is like a millimeter that way, it hurts in your leg. A millimeter that way, it's okay. Okay, you're coughing like, oh, what's that done? Oh, God, it's a bit sore. And it's just shifted it a little bit. So by changing it a little bit, you might find it's a good day, it's a good week, it's a good month. Okay, do something to irritate, it's a bad day, bad week, bad month. And almost like neuropathy can work like that. Okay, yeah. So it's up to you to try to alleviate the pressure. Looks a bit weird, the technique. Come down the couch, please. So the knees are hanging off the edge. Just keep swimming. Just keep swimming. Keep going. Just keep. What film is that from? Just keep swimming. What film is it? See, good. Arms hanging, please. Head to one side. If you hold on, you activate the lats. The lats connects to the glutes. The glutes connects to the sacrotuberous ligament and increases force closure. Okay, relax. Head to one side because when you pull the leg, watch the neck. Okay, the neck will extend. So head to one side, it relaxes a bit more. Now, what we're going to do is bring this right side PSIS down, or the whole innominate. I use the leg and I straddle it. The leg I turn internally, and it is why? And it is why? So I lock the hip in. If I do not turn the leg in and pull, I'm affecting more of the hip joint. If I turn the leg in and lock, I'm affecting more of the SI joint. It's not an SI manip, it's an IS. Okay, I'm pulling the ilium down on the sacrum. The sacrum stays where it is, and I'm pulling this down. The sacrum doesn't do anything. Okay, so even though it's an SI-ish, I'm moving the ilium on the sacrum. Now, I can palpate the PSIS, and I can feel the opposite hamstring. Okay, I'm just stabilizing here. I cross my leg, and I come onto my toes. You'll see why, because I simply squeeze my leg and straighten the leg. This right PSIS is coming down, see it? Okay, the spine is side bending. Okay, so I'm opening the facets on that right side in here. I can literally palpate the PSIS and just simply straighten and mobilize her spine by doing this sort of technique from there. I can literally just do this, so I can just literally straighten, and it's that technique. You can say to your patient, to activate the QL, lift your leg up, please. Okay, rather than going that way, go the other way, that way. So she's hitching, so she's activating QL for 10, 9, 8, and so on. After 10 seconds, the QL will relax through post-isometric relaxation. Relax, let go, let go. Take a small breath. And as she breathes out, I straighten my legs. Watch now, a little thrust at the end. From there, nice little clunk. Okay? Yeah. For some patients, it has been miraculous. Okay? Okay, it's almost been miraculous in terms of their symptoms. I've had patients who have had chronic pain for years and years, and I've done one technique, and it's been like, wow, that really helped. Okay? And I normally just do it once, and then if I hear it and feel it, as in it went clunk down, then that seems to work quite well for me. Now, move back up the couch, please. How long does it last for? I don't know. Why do chiropractors treat you 3 times a week? Because they can. Yeah, but you might find that if you have treatment, there's one argument, if you manipulate and you walk out, it might come out again and all that stuff. So, but if it's been sitting in an incorrect position for a while and you change it, you might find that it can stay there quite quickly, because it's changing it in a different way. It's not like rotating the L5 and it comes back and back. Okay, this is just changing the position in. And then reassess. Okay, come on and see if it changes. If you don't like that technique, because some people won't want to do it on certain individuals, where especially if a woman straddles the leg of a man, is maybe inappropriate, depending on where you are. Even though they don't really know what you're doing, because they're just there and you do a leg pull. It's over before you think about it. If you don't like it, come to lie on your back so you face up. So we want to do the right leg rather than the left leg. You can check the leg length from here if you wanted to. So we bend this knee to stabilize the pelvis. So this technique, if the leg is out, we mobilize the hip joint, and that's quite nice in itself. If we want to affect the ilium, we turn the leg in, and then we traction it this way. Okay, I can feel the ankle is mobilizing the talocrural joint in here. So from there, I want to try to stabilize the ankle, even though you probably have a little gap, so I can lock and I can thrust. The downside with this one is I can't feel the PSIS. It doesn't feel quite the same as the prone one. But everything has its place, okay? This works quite well. If you're not sure, this works. It's also quite nice for an ankle as well, okay? If you wanted to mobilize an ankle joint, it's okay. Yeah. 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 You okay?
Mm-hmm.
Yeah. Let me just check that leg length while you're there. Yeah. So from there, just to level things a little bit. Sometimes I get them to bend the knees and lift up and down 3 or 4 times. And coming down, that's okay. Maybe not. No. Well, I did an MET prone. I asked them to contract QL and bring it down. But then this one is almost traumatic to happen. So it has to be a reverse direction thrust. So if it's forced up, you force it down. Okay? Yeah, and nothing else will almost correct it. It has to be an equal force going down. My friend who looked after the bobsleigh team for 6 years, Gordon Bosworth, quite famous in the physiotherapy field, he almost does this on everybody. Okay, he's famous for it. But when he moves it, he will move it. Okay, but it's almost unbelievable when he moves it. It's, yep, bang, ding, and he's like the pelvis physio. He's like the pelvis god, really. Okay, so, yeah, cool. Oh, thank you. You okay?
Aye.
Yep. Interesting to see how you feel over the next day or two. Because she has adjustment, she said, a couple of times a week. Yeah, for a lumbar spine. So, but it doesn't always, if you're adjusting the same place all the time, you got to say, well, but on a pain scale of a 6 she was on, she's now around a 2. So it's helping her, yeah, over the course of treatment, yes? Mm-hmm. Yeah. Okay, so, and if it's helping, then it's a win-win, really. Yeah. The downside is if you don't work in the clinic, you gotta be, there's another 30 years, there's another, yeah. Okay. So can you try that? Because time's getting on. So that's the leg prone thrust technique. That's probably one of my favorites.
I quite like that. I hadn't seen it done showing no session. I'll definitely try that one. I do spine. It's purely just because you're just
You're already there.
You're already so why not?
Yeah.
And a lot of, if I'm being honest, a lot of things we choose to do are Depends on what they're wearing, what just circumstances.
Yeah, no.
That's it.
Yeah, just working the free with someone.
Okay.
Yeah.
You work with me.
Yeah, you try.
I don't mind because I mean I don't think because I'm in a chiropractic clinic I wouldn't do that separately. I would do more of the mobilization.
Yeah.
So if you want to,
Yeah. You can try me if you want.
Can I?
Yeah. Will you make me taller?
I've been very nicely. Very nicely. It was good.
Is that going to work for you? Oops. You don't have to be too gentle with me, is all right? So you feel the iliac crest, the PSIS, and the ischial tuberosity. Okay. Do both sides. Yeah. That's all right. I could fall asleep. Yeah. Turn my leg in. Internally to lock the hip joint. Yeah, that's it. Yeah. Yeah, palpate the PSIS with your left hand. The right hand stabilizes the hamstring, so it stops the leg from moving. And have a go at traction to the left leg. Yeah, yeah. Yeah. Fingers lightly. Yeah, that's it. Yeah. 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 Good. More pressure. Yeah. Good. Well done. Yeah. 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 Good.
I just cavitated one back doing it in the Wednesday.
Yeah. Go on. Yeah.
Turn the foot in. Like, and then like, yeah.
Yeah. Palpate, that's it. Feel the PSI, that's good. Yeah, good. Yeah. Yeah. Good.
Yeah. Oh.
Yeah. Nice. Well done. I don't mind, but you know. Yeah. Thank you.
My high five. Thank you.
Well done.
That one is wet dog.
Yeah.
That one is as well. You have your hands here. You're doing that. That gets sore as well.
Psoas.
Yeah. So you know, like.
But it will a little bit.
Yeah, Jake can teach them, and then you sit down.
All right. What do? Okay. What am I doing?
So you like that face stuff?
On or off? Joking. Just teasing you. It's off. What do you want me to do?
Face thing.
All right. Sorry.
Okay, so that one,
Yeah.
and then like you,
That's good.
and you sit down.
Who sits down?
So well, you can't see me. But
I sit down. All right. Okay.
I'm doing that because I'm trying to sit down.
Yeah. And you say what? Psoas?
Yeah, do you feel
Why? Why would it be psoas? Yeah.
John, am I okay to get my bit done on there or no?
Yeah, you're okay. Yeah. Maybe both sides. Well, from scoliosis, you'll have a high side. Yeah. Yeah. Yeah, you'll be okay. Yeah. No, no way.
Where are you feeling that? Are you feeling that more in the trail?
No, where your left hand is on the ribs, on the thoracic spine. It's almost like a counter rotation for the spine. I would say it's more of a spinal motion and a rib mobilizing, rather than the psoas. Yeah.
Yeah, well, that's it.
Yeah.
As I grabbed you, you could have started twirling around.
It's good though. Yeah, I like that. It's all quite nice, isn't it? Really. All techniques are quite nice to a point.
Oh, it's nice. Isn't
Yeah, it's
it?
nice just to have contact.
Practice with me. Practice with
Yeah,
me.
just take your time. Just whatever you do, just take your time.
Yeah.
Yeah,
No,
just
not
do it
feel
slowly.
like you do it again.
Yeah.
Did you?
No.
Right.
Yeah. With a jig. With a level 6 now. Yeah. 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 I know what I mean. Yeah. I'd almost want because she's my PA girl at SJ. Yeah, so she does like all my admin, all that stuff. Just I'm not very good at that stuff. Yeah, I'm trying to get my courses affiliated in the US with CEUs. But yeah, because that's BTEC, isn't it? Level 6 of Jing.
Yeah, Rachel was saying it was a fair bit fab.
Yeah, it's always a fab. Everything's a fab.
But
Trying to get.
I honestly just think that level, what yours is at.
Yeah,
You know, like,
yeah. Maybe I'll. Yeah.
Or even
see,
above John as well, like
Yeah.
6 and above. Is my opinion.
Well, I think it's because of the length of time on one area that you teach.
Yeah.
And the depth that goes into it, and then you go away, and that's what I like about your course as well. Not bumping you up or anything, but
Yeah.
you can go away and you do it, and you perfect it as much as you can, and you keep learning it without doing something like this every day or every week, a weekend out of every month. Sometimes it's just brainstorm. And when do you actually put it in? You're thinking, did I do that? Did I not do this? And I think sometimes some of these courses, although they get themselves affiliated, whatever, and accredited, but they're still all teaching something different, aren't they?
Yeah.
You know, the active IQ, although although some of the courses are like active IQ, but if you go to somewhere like STO, they'll say, yeah, but how much face time did you get? Well, it doesn't matter, I've done the course.
Yeah.
No, we need to know how much face hours you got in the classroom. Like, why are you crediting the course? So there's, you know what I mean? I don't know what I'm talking about here. I know what I'm talking about, but I don't know how to get it out. But what I'm saying is that some of the courses that you do.
One sec. Bend this knee.
Oh, sorry.
So when you pull,
Yeah.
you only affect this leg rather than affecting that leg. Yeah. Because when you pull, yeah. So it's only, you have to affect one rather than both sides. Cool. Everybody good on that one? Yeah. Nice. Good. Did you turn a leg in?
Yeah.
Yeah, all right. Good. Okay, next one.
can also see
Louise.
exactly
Louise?
what you can
No,
feel
yeah.
yourself and
Can I use you?
Yes.
So this one, if you have a lie on your left side to me. So this one will be potentially the most common dysfunction you will find within the pelvis. What do you think that is? On the side towards me? A right anterior rotation. There are many books, not just my book, because I didn't do the studies. It just takes too long. And if I'm honest, I let someone like this lady do the study. I'm not interested in that side. And normally it's the physios do all the research, isn't it? It's true. It's true. It is. Yeah, when you look at most of the researchers, they're all mad, academic. They're not really mad, but you know. But they like to do all of it, and I just go read it and go. And when I read, I don't read it. I just go to the conclusion. What do they find? Oh, okay, that's all right. Yeah, rather than reading a page after page on the statistics, which I don't understand anyway. Yeah, I just read what it was about, what do they find, and that's me done. Yeah, rather than reading the 20 pages. So in terms of the information around this condition, the most common is the pelvis on the right has gone anterior. And there's a book by Wolf Schamberger, who I've mentioned in my book. And basically his book, which is 600 and something pages, is basically about one condition, an anterior rotation. There's a few other things in there. He's got like a chapter on horses and riders and stuff like that. So the horse is out, riders out, horses out. Yeah, and it makes sense. Okay, it makes perfect sense. And so that's an interesting chapter. But he is literally mainly talking about an anterior, and then he's also referencing other studies by Klein et al., and they talk about an anterior rotation, etc., etc. So that's what they discuss in other literature. So I mentioned it in mine. Why is it right side? I was just trying to chat with SJ earlier. If you kick a ball, what leg would you use? More likely, yeah. Most of us here, wouldn't I, would kick with our right leg. Yeah, we probably would lead with a right leg. Yeah, that sort of thing. You know, we're right hand dominant, right leg dominant. Maybe that's part of it. Okay, yeah, maybe not. But that's what we found. In terms of findings, if you have a right side that's anterior, the leg will appear to be longer or shorter in lying. Longer. Okay, so they will appear to be longer. And interestingly, Schamberger has a test called the long sit-in test. And if you just sit up for a second. Mm-hmm. If Louise, and face that way.
Faces.
Yeah. So if you're in this position, let's say, for instance, I'm not going to do it. If the right side in sit-in appears to be shorter and the left leg appears to be longer, okay, so right leg short, left leg long in sit-in. As the patient lays back down, the right leg goes longer as they lay down. And as she sits up, the right leg now becomes shorter as she sits up. And as she lays down, the right leg gets longer. If you notice that with a patient, okay, they've got like a functional leg length discrepancy, and more likely it indicates a rotation. What tends to happen is, because when you sit up and lay back, both legs should equally move together. If there's a just functional side, if the right side is anterior, as you sit up, the left leg goes past, and as you come back up, the left leg comes back. Okay, even though we discussed it's the right leg is dysfunctional. Now, so you might see that. So if you do that test, and they call it the 5 L's, so the leg lengthens lying, landmarks lower. So the 5 L's. So as you sit in to lay, so the leg lengthens as you lay, the landmark is lower, as in the malleolus is lower. So that would be a little test you could maybe do. The ASIS will be inferior, the leg will appear longer, the PSIS will be superior. Okay, there's a few things you might maybe be looking for. If you've got an anterior rotation, is the hip flexed or extended? Flexed. Okay, so what muscles will be tighter? The flexors. Okay, so the psoas might be tighter on the anterior side. But you might find when you palpate the psoas, the left side is tender, and you might treat the left side, but the left side is tender because it's compensating for the right side. The right side, according to Schamberger, locks in, so the left side, John, gives you pain because it's compensated. And if you treat the left and treat the left and treat the left, nothing happens because the problem's on the right side. Okay, remember, don't chase pain, chase dysfunction. So you're looking for dysfunctional traits rather than saying, where does it hurt? Okay, where does it hurt? Yep, so that's what you're looking for. On your side towards me, please. So if you wanted to correct an anterior rotation, this is like an MET into a manip, a bit more towards me. Remember my patient to me? Okay, I never, ever go to them, ever. Top leg, knee, hip, as in you a hip, her knee. So that's where we are. So from this position, palpate the PSIS, flex her hip until you feel it starting to initiate posterior rotation. Because if this has gone forward, we want to bring it back. The technique is easy. You a knee, my hip, push me away. 10 seconds, 10. So she's using a glute and hamstring. Contract, they do all the work. In fact, one of the students yesterday said, look, I'm not sure who that was. It wasn't you, Amanda. Amanda, was it you? Oh, man. Yeah, she was saying, that John Gibbons is lazy, isn't it? What did you say?
Yeah, I said, oh, I'm going to John Gibbons' coach. She went, I'm not sure about John Gibbons. I said, why? She says, he seems very lazy. He gets all his patients to do the work. I went, yeah.
Yeah, exactly. Okay, yeah. So after the 10 seconds, so she's contracted, then hand on the ASIS, forearm on a PSIS, and I'm going to rotate my pelvis of the patient posteriorly. Okay, so I rotate it back. This also works to open the facet, stretch the lumbar as well, in here. From here, push again, please. So she's pushing. 10, 9, 8. After 10 seconds, relax, breathe. And as she breathes out, encourage that movement. This is a little technique I call an encouragement. It's not really a manip, you heard? Okay, so from there, I'm doing a little thrust. It's not going to cavitate. But the idea is that I'm trying to bring this pelvis, or this right side, innominate, posteriorly. Okay, and that works quite well for me. If you don't like this hand positioning in here, okay, you can literally come around with a hand on the ASIS, hand here, okay, get permission if you're doing this, and then you are going to mobilize coming through. I prefer this hold, yeah, and I'm coming through it, but I'm using my hand to mobilize and my body to flex her hips, yeah? If you don't like it because you've got a knee problem, modify it so she's hooking around you, so it doesn't irritate the hip anymore, and you push me away, so she does all the work again. Okay, while I'm Instagramming. Yeah. Relax, breathe in, breathe out, do nothing, and I'm mobilizing again. Okay, or hand, and I'm mobilized. And that works quite well. That is a good technique for general back pain. Okay, where you just mobilize. Because when you're walking, remember from this morning, when you are walking, the nominate is posterior, the nominate is anterior. Posterior, anterior. So it's natural functional motion. Once you've done this one, you'll then do one more for the opposite side, because if this one's gone forward, the other side is compensated and done and gone back. So this has gone forward, doesn't come back, and this has gone back and doesn't go forward. So by you trying to encourage that APPA motion, allows that natural type 1 motion of the lumbar and sacrum. Yeah. Okay. And that's a very common technique or common dysfunction you will find within the pelvis. It's like the shoulder. If you said like there's 1,000 conditions, but someone's got shoulder pain, and you said what condition? So your friend's shoulder hurts, what would you say without thinking about it? They've probably got an impingement of the supraspinatus or the bursa. And probably 90 to 95% it will be correct. Yeah, and if you treated the supraspinatus, how did you know that? Well, because 95% of shoulder pain is probably the supraspinatus. Okay, most of the rotation of the pelvis is 80, 90% anterior. Okay, and then you get a bit of an upslip and a bit of a rotation the other way, and yeah, so it's okay. Almost trying to keep it sort of simple. Good, have a go, please. Couple more, and we are done. Probably just after 4:30 if you're wondering about the time, but it's okay. I'm only drinking alcohol later, so it doesn't matter.
Am we okay to do?
Yes. Yes.
Yeah,
Yeah.
on the right side.
Yeah, it's fine. Yeah, because it's an MET and it's safe. Yeah. Yeah.
You guys, you can go.
Yeah.
Yeah, I quite like that way because you can hold the ASIS with your hand and lock in,
Yeah.
and use your forearm, and then use his hand to help out on.
Yeah.
Yeah. Yeah. That's good, Jerry. Yeah.
No more like
Try rather than that way, it's fine. Try put your hand right over the ASIS and forearm on the PSIS, and this hand guides that one. So use your body weight to rotate the pelvis. That's it, like that. You might prefer, you might not. Okay.
yeah.
Yeah. But rather than just doing that, you can't just do A. You have to do A with B.
Yeah.
Okay. So as you are there, so he pushes, push me, 10, 9, 8. It's not just there. Use your hip and move. Move. Okay?
Yeah.
So use both. Okay? That's it. You don't need to hold that. Forearm. Use your body weight to go forward as you rotate his pelvis posteriorly. Okay? Good. Well done. Try. Hand there. It's like a climbing hold, that one. Forearm.
Yep.
Hand to guide.
Right, okay.
So this is the rotation. There we go.
Better.
Yeah, nice. It's okay. Yeah. On there. Good. Well done. Change your knee a little bit. Change your position a little bit. Okay. So either like there. So it rests on your almost like ASI's hip there. And maybe don't go so far because you were right up here. So maybe start here, come over, and then you can mobilize it. Yeah. Or she hooks around you and you lock her in there. Okay. And then it's the same technique. Okay. So you decide.
So it's not about the flexion so much, like
No.
the move here.
No, you have to try to get the innominate move because it's an innominate problem rather than a hip problem. Yeah. Yeah. Good. I'd probably swap sides. I'd probably use your left hip here rather than your right. So that's resting there. This hand on the this one. Hand on the ASIS, like a jug hold, like a climbing hold. So you hook into it, forearm on the PSIS, and to stabilize. So it's not just that, you use your body weight to flex your hip as well. There we go. Okay, so don't be too shy here, okay? Because it's a pelvic problem rather than a hip problem. So you use your hand to encourage a mobilization here. It's good. Well done. That's good motion testing. Good. Who showed you that?
You?
Sorry? When? On Derry? No.
No, it was in uni.
Oh, okay.
In uni. Yeah, I did manual therapy in uni.
What you call it? What was the degree called?
No, the degree was sport rehabilitation.
Okay. Where? Where'd you do it?
Salford.
Okay. Oh, okay.
The module was manual therapy.
Yeah. All right. Well done. You too tired? I am.
Do you look it?
No, I do.
I feel it.
Yeah. I've done 11 days on a trot before. It's ridiculous.
I feel as if the gas doesn't help. Like I feel as if my eyes
Yeah.
are really like
Yeah.
dry.
Yeah. Well, yeah. I wouldn't probably want to do too many days. Yeah, maybe I'll do a summer one next time.
Well, we were saying we're going to come to. You got one at the end of February.
Or pelvis.
No, I don't know what.
End of February.
End of February in Swindon.
I've only got the 25th to the 27th in February.
Yes.
As a 3-day pelvis.
I know. I don't know if we'll maybe wait and do it later on in the year.
Okay.
Work with what we've done.
Yeah.
And then,
Yeah.
or will we struggle to get all the dates fitted in? Do you think?
I'm not sure when the next pelvis one would be, so if you can do it, it'd be good. But if not, don't worry.
Okay.
It's up to you.
So
Okay.
double C.
I'll just see. Because there'll be space for you. Because I've got like 10 on it.
But that won't be in Derry.
No, that'd be in Swindon.
Swindon.
Yeah, I'm not sure if I do a 3-day one in Derry because they probably want like 1 day K-tip, 1 day MET, 1 day shoulder, something. Yeah,
Okay.
something like that. Yeah, which would work for you in April, maybe, probably. Yeah, good.
Highly recommend them.
What's that?
Shoulder and
Yeah.
You're amazing. Yeah.
Well, they paid for the diploma as well, so they're doing all of it. Yeah, just trying to fit the dates in, innit? Yeah. You'll be made. What's that?
You don't have to have them completed in a certain amount of time.
No, it's not much. Now, I was going to consider just bringing it down to like a year or two, but I thought, what's the point? With the COVID and all that stuff, people are struggling with time and all that now. Yeah. But you'd be amazed how many people are doing it online. I've got a guy at the moment called Attila. He's doing a course a day online. I'm like, how are you doing that? It's just ridiculous. You know, he's saying
take it in?
you can't. And he's not even watching all the videos anyway. He's not watching any of it.
So do we don't have access to the online videos, do we?
Well, most of the videos are on YouTube anyway.
YouTube, right?
Yeah. You know, you could try an online course. Do you know what I mean? If you wanted to. If you wanted to, just let me know.
Okay.
And then just try one and just see what it's like.
Yeah.
Yeah. You know, like something that's whatever you're already good at doing. Like maybe K-tip or MET or something, or try. You could do one or two and just have a look. Yeah, it just saves you the journey of the time. And you will learn more, potentially, because it's quite full on. Like a shoulder one is ridiculous. Like 80 assessment, you have to really eat it. Yeah. Just have a think. Just if you do, just let me know. I'll just send you the links over. And then you can try one and just see what you think. Because you might go, oh, I like that. I could do another one of them. Yeah. You know, to be amazed how many people are mixing and matching the courses. Like you've done a couple online, haven't you?
Yeah, I've only got 3 left to go.
Yeah.
From the diploma. So I've done this online. I've got taping, which I kind of started. I've got Thoracic Spine and...
Yeah, like Teresa's done them all. She's done them all now, Teresa. Yeah. She sent me the certificates yesterday of all the ones she's done. Yeah. Okay. Last couple. Right. Okay. You want to come round? Can I use you? Come. You lay in front. Yeah, let's go out. So let's say, for instance, you've corrected the right side and you've brought it back. The left side, you'd probably want to bring it forward. So anterior on the right, posterior on the left. You've brought this one back, but this side we want to just encourage a little bit of forward motion. Because it could be this side is a problem as well. Yeah, you know, we say anterior, but on 80% of the population, it might be that the left side is posterior, and that's the primary. Okay, so it's, you know, when I taught at, I'm not sure it was, the Saracens, I think, in rugby, I was watching one of the physios, Prav, he's now the Welsh. The Welsh not really did that well yesterday, I don't think, but, you know. But, yeah, I know. What's that? No, we did rubbish. And I've even taught at Wales Rugby Union as well, a few times. Yeah, anyway. I'll just cry later over a gin. Again. 2. Yeah, just at one end. Right, knee down, push down. So he's activating. Again, he does all the work. I'm on my Instagram again. 10 seconds. Relax, breathe. So he's done the work, activating the hip flexor, rectus femoris. 10 seconds later, this will be the easiest one to do. You have a choice. You either come under the knee, okay, with the knee bent or leg straight. I'll show you both. So if you do the leg straight, from here, this is probably a slightly easier one when you've got a heavier leg, because from here, I can mobilize you, okay? Yeah. So you pull the leg, extension, adduction. You push the PSIS away from the midline, okay, around 30 degrees. There's no point pushing it this way because you're going to compress the SI joint. So you want to go at an angle away from you, mobilizing this way. Sometimes it clicks, this one, but I'm not really sure where the click is coming from. I think it's the L5 that clicks. There you go. That was a little release. Rather than the iliosacral joint making the noise, okay? Everybody says to me, how many times you do this, you know, do it 4 or 5. I never say numbers ever. You know, if I'm doing a technique, and I don't say you do it 5, because you'll be obsessed with the number. Okay, was that 4 or 5? I'm not sure. And you think about the technique, as in the number, rather than feeling for, is it a change? Okay, yeah, so I normally just suggest you just do it until you feel there's a change to the tissue, and then you leave it alone. With an MET, it's normally done 3 times. Okay, so they contract, they relax, new bind, contract, relax. Whereas this one, if you have a knee bent, the reason why we have a knee bent or not, if a knee bends and his pelvis tilts, what muscle is tight? Because this will be the test of Eli. the rectus femoris, okay? And it almost pulls it too much. So with the leg straight, the rec fem's out of the equation now, okay? So because the focus has to be more on the pelvis rather than using the muscle, okay? So from there. So if you wanted to bend the knee, you can, depending on the tightness of the rectus femoris, okay? So from that sort of area in there. If the leg is particularly heavy and you are struggling with the weight, just ask your patient, Callum, just lift your leg with me, there, okay? The downside is when he's lifting, he's using his glutes, and the glutes blocks my pathway a little bit. Are you okay? From there. Be careful you don't go too far because it irritates the L5, because it extends the spine. I am just going to do one more because I'll be the last one. So that's quite an easy technique and it works quite well. Have a lie on your back so you face up. Now, Philip Greenman, when I was an osteopath student, they would recommend The Principles of Manual Medicine by Philip Greenman. And in there's lots of techniques. And one of them is what we're going to finish on. So this is known as the MET for the pubic symphysis. According to Greenman, he says the pubic symphysis here either goes inferior or it goes superior. And I quite like that because it's almost simplistic. Yeah, it either goes down or goes up. I'm like, okay, I'll go over. All right, and he's obviously a god in manual therapy. Most schools in, say, the US, etc., the chiropractic, osteopathic, will follow his sort of concepts. I'm hoping they put his book to one side and just use mine, but we'll see. We never know. So from there, so it goes down and up. So it's not one of those areas that we tend to palpate very often because of the proximity to everything else. But if you were to palpate it, okay, I'm not going to do it, okay? Pubic bone, come down, and just quickly look at your thumbs. Yeah. Look for the level, rather than going, I'm not really sure. Michael, come and have a look. Yeah, what do you think, Michael? And she's like, what? Just like, what do you think? Okay, don't go down now. Right, you'll be in trouble. Okay, if you're going to do it, on, off, done. Okay, up or down. If it's tender and it's not level, then more likely the pubic symphysis is not sitting right. But that's what, but you might get pain anteriorly in the groin. You might also get pain posteriorly in the back, because if it's out in the front, it's out in the back. The ball is three-dimensional. If it's out here, it could be that you kick the ball and you tweak the pubic symphysis. Lady, pregnancy, relaxing the hormone is shifted and it's not sitting right. Okay. If you had a cesarean, maybe wait a couple of months for it to settle, maybe 3 months for the scarring, etc., to heal correctly. But potentially you could teach horse riders, you can teach them how to do it themselves. Now, when we're doing it, bend both knees, please. So from here. So this is also known as the shotgun technique because it can sound quite loud. I doubt it will on you, but it will only maybe one or two of you. It will release if it needs to. Like on a Friday sometimes when I'm in my house, Denise is there, and she does a technique. She's just sitting there, you know, eating a popcorn, watching a film. And next minute I can hear this like pop. I'm like, what was that? And it's like, oh, she's like, oh, I just released my my pubic symphysis, just carries on with the popcorn. I'm like, living a dream. Living a dream we are here. Yeah, yeah. Pubic symphysis releases on a Friday night. What else is there? It's probably just a popcorn. But it's just, it just sits there, she's like, so what are you doing? Sorry. So let me do it. So, legs apart, please. So the technique is quite easy. I've even taught husbands to do this on their wives. Okay? Relax. 3 times away. The idea of abduction, push, tells the adductors to relax through inhibition. Relax. Yeah, what was that? Oh, yeah, okay. And you did it yourself, really? No. No. 3 times out. Technique number 1. Fist between the knees. Squeeze me as firm as you can. Tight, tight. Oh, there you go. It released. I was impressed. Okay, you can. I don't know if you heard it, but it's not like a shotgun noise. Okay, sounded like it was more on your left, but I could be wrong. Yeah, yeah. A lot of times, men in particular will, or the hands just rush down. What was that? That's a bit weird. What was that? Yeah. You know, check if I like a damp patch. Again, can I weed myself? No, you're okay. Yeah. Not when you're younger. Anyway, it's one of those, isn't it? I know. It's on film. It's on YouTube later. Yeah. So if it didn't go on the squeeze of the knee, then what you can do is the thrust. And the thrust is hand, and then we would normally ask the patient to squeeze in. And as they squeeze in tight, we separate quickly. But it went on the thrust, which was I'm surprised it did. So just to recap, knees apart. And I normally sit up in here, especially for women, because women are so strong in the abduction. Okay, so I normally have to come right over to prevent that motion. So push out. So they push, and I don't know, say 10, 20% as they push out. I normally do it 3 times. On the 3rd time, breathe in, squeeze, almost try to break my hand, squeeze tight, okay? And then sometimes it releases. If not, squeeze in, tight, and you separate as they contract. And then that will be the pubic symphysis. And it does seem to work quite well. Gordon, my friend, the bobsleigh guy, he tweaked his groin. The medic said, let's put a steroid in there to reduce the symptoms. He went, I prefer not to have a steroid in my adductor, thank you. He went to see the physio, and the physio, Gordon, said, okay, he was out in the back, corrected, as in about leg pull, and then he did this technique, retested the adductors, no more pain. Okay, so because where the ramus of pubis is changed, the adductor longus in particular is going to be obviously tensioned a little bit differently. So by trying to correct it, but I don't know where the click is from. I don't think it's a gas release from the symphysis pubis because it's not the synovial joint. It is a cartilaginous joint. So more than likely it's the change of position from the ligament. Okay, so I think it's the ligament clicking, yeah, rather than gas being released from the joint, yeah, like the thumb. That's the last one. So we got a posterior correction and we got an MET pubic, and then we are done.
John, would you always do that from that position?
Well, I can do. You can do it from this position.
Or would you have them put a dedicated view?
Yeah. You have a choice. So we come down, so you can just stand here. Yeah, you can just stand and do that. Yeah, do that. Or you can stand on the side. Okay, hands either side. Okay, and then you can just pull apart or push apart. So you do it. Do it on the floor. In fact, I've seen it done on the floor where you just put your leg between their legs and they just squeeze your leg. And that works quite well. Like with cyclists, they get off a bike, you step between their legs, squeeze, and then it can really, because on a seat, the motion of the pubic bone can be irritated. Yeah, probably not 15. You probably don't need 15. It's quite hard work, 15. Probably more like 5 to 10. Yeah, so he pushes out because it is quite hard work, that one. Have a go if you want, please. Thanks. What's that? Yeah, let me give you some. I got certificates if you need to go. Where